our academic feast, both for hematology and CLIA chemistry. So, in the past 2 days, we have learned and earned so much of knowledge from the stalwarts in the industry. Now it is time to return back to the industry, as Dr. Venkatesh rightly said. So, we should implement and apply this knowledge in our day to day lives. So, without further ado, because it's already time, our first speaker for the day is online. And I may request Dr. Barnali. Dr. Barnali, I can't see you.
I'll just call her. I'll just call her.
Hi, Dr. Barnali.
Yes.
Good morning.
Hi, hi,
And sorry
hi.
to keep you in the office today.
No, no, good morning. Good morning, everyone.
Yeah, good
Thank
morning.
you.
You can see me?
I can't. I can see only Mindray.
Okay. So now you
Yeah,
can
yeah,
see
now
me?
I can see.
Yeah,
Yes,
yeah,
yes.
yeah.
Thank you
A
so much.
very,
Yeah.
very good morning. And thank you for coming. Thank you. This is urge, this is an urge for returning back the knowledge that she has. So thank you so much. So let's start for the day. I
Thank you.
request
Thank you.
Dr. Venkatesh Thuppil to chair your session, please.
Thank you, sir. Thank you.
My dear Barnale, I'm very honored to chair the session. And I know how hard you have worked and how much of knowledge you have accumulated. I know Dr. Barnali for a very, very long time. For me, she is a small girl. I tell you, I am like a grandfather. Dr. Barnali, after her MD, DNB, postgraduate diploma in HHM, and so several other, list of A to Z you can add, and lead consultant, biochemistry, immunology, laboratory, and medicine in Kokilabane, Dhirubhai Ambani Hospital, which I had visited at Mumbai, and she is a fellow of the Association of Diagnostics and Laboratory Medicine, which was formerly ASCC, American Association of Clinical Chemistry, the chair association of and for diagnostics and laboratory medicine. She was formerly an American. It was formerly American Association of Clinical Chemistry. Executive member, scientific division, International Federation of Clinical Chemistry, blah blah. So many things, I tell you. I wish I had one or two such uh, uh, credits to me, and she has excelled all of us. Really, I'm very happy, Barnali, that you're a member of AICC subcommittee of Global Affairs and West Zone Council member. You are a life member of ACBI. You have delivered several orations, and I'm very happy to tell everybody she is one of our very favorite NABL assessors, and also of CAP inspector, evaluator, and review editor for Practical Laboratory Medicine of Elsevier, and editor in chief for Aki Special Issue, and editorial member of other journals. At a very young age, you have achieved so much. You deserve more and more awards and accolades. And she is a winner of various national, international, awards and many publications, is in renowned national, international journals. Barnali, we are very proud of you, and we are looking forward for your talk on defining, establishing, and verifying the uh, uh, your subject of great interest, the reference intervals, particularly. The reference intervals is a big challenge to a huge country like India because of nutritional variation and genetic variations and things like that, which is a key in hematology of harmonization of our reference material in Indian population. Welcome, Dr. Bardali. I will not take much of your time. Looking forward for your very uh, interesting talk. Over to
Thank
you.
you, sir. Thank you. Thank you. Thank you. I'm honored that you are chairing my sessions. I'm truly honored because whatever we have grown and in the quality journey, so your mentorship make a lot of difference in many of our life. So thank you for chairing the session. So today my talk is, you can hear my voice?
Yeah. Yes, ma'am. Yes, ma'am.
Okay, clear. So today my talk is defining, establishing, and verifying reference interval. So this is key to harmonization of reference interval in Indian population. So being a technical committee member of ICMR task force for reference interval in Indian population tariff. So I thought when Shama asked me, about the talk. I thought this talk about reference interval and clinical decision limit many times cause a lot of confusion in our mind, in clinicians' mind, in patients' mind. So as we just celebrated Patient Safety Day, so I thought this talk will be appropriate for SFCC. And I have taken two. One is the TSH as a reference. Another is the high sensitive troponin I as a reference. Why? Because TSH we use reference interval, and for high sensitive troponin I we use mainly clinical decision limit. So I will show the difference between these two, how to establish that, and our case study in our hospital lab. So thank you, SFCC and Mindray, for inviting me and giving me this opportunity. And as I'm member of IFCC and also ACCLMP, I'm very much thankful that to IFCC and ACCLMP for organizing this conference. And so as I mentioned that we just celebrated our World Patient Safety Day. So when we talk about patient safety, harmonization, standardization, and mainly rationalizations of our laboratory tests are very much important. So are we nearly there yet? So for us diagnosticians, every blood sample tells us a story. So let's see how. And this is my painting to acknowledge all of our efforts, all the diagnosticians' efforts. We may be doing and reporting the tests which are done in autoanalyzers. Some we are seeing the slides under microscope, and some are doing RT-PCRs in histopathology. They are seeing slides and reporting. So different diagnostic divisions, we are contributing towards the patient safety, towards the evidence-based medicine. So if to acknowledge the true healer, so the lab personnel, so I want to acknowledge through this painting. So when we talk about total testing process, it starts from pre-examination to pre-examination, then examination process, then post-examination, and post-examination. So this whole process, or Ludenberg loop, or total testing process, brain-to-brain loop, which we say. So what are the main components? Identifying the risk factors and symptoms, diagnosing the disease, determining the appropriate treatment, and evaluate the response. So all in this, the clinical decision limit or reference interval play a very significant role. And the quality of clinical laboratory service is critically dependent on the quality of lab operations. And in all the testing process, from pre-examination to post-examination, quality and accurate and precise testing process, validated methods and systems, appropriate reference of lab results based on appropriate reference interval and clinical decision limits, and key to ensuring post-examination quality of the lab reports. Wow, what is this? So this is our today's lab system. So this is one patient has gone in 1 or 2 days time to 3 different labs. And if you see the value variation, one lab reported 0.02 microinternational unit per ml. Another lab reported 1.67 MIU per ml. So MIU, so you see the units. And third reported TSH 0.1 MIU per liter. So see the units difference, and also like not clearly mentioning, is it micro or is it milli? So this you can see the difference in the units, difference in the values, 0.02, 2.1 to 1.67. So with this kind of report, patient goes to the clinician or endocrinologist, and he's thinking which lab result to believe or which one is a good lab. So if we see today's process or today's lab system, patients are coming with burden of disease, if you can see, and then in our lab life, we use our intelligence, discipline, and creativity, and then patients are going out with reports. So either we are getting call from our clinicians or patient feedback. We are getting, oh, Barnali, what report you have generated this AKI, acute kidney injury alert. So this is helping us so much. Or sometimes they can call us and a clinician can call us and say, oh, for your report, this is a false alert for acute kidney injury. So this is today's lab system. And if you can recognize this person, it can be you or me. We being an ABL, SSR, or College of Medical Pathologist inspector. So we go to a lab and we do sample audit, and based on that, we say, like, so and so no deficiency or non-compliance, or so much deficiency or non-compliances. So this cartoon is today's lab system. So what do you think, why there are so much variation? Do you think this sample integrity is issue because sample are transported in different modes of transport? Do you think in this case of TSH, sample integrity is issue, or harmonization and standardization is is issue here? So thyroid hormone, a very simple hormone, thyroid function test, we are reporting in lab maybe 100 to many labs report around 1,000 thyroid function tests a day. Or is it harmonized? The reference interval, are they harmonized? So these are some of our articles about adoption of more uniform reference interval in European Thyroid Journal, Clinical Chemistry, Clinica Chimica Acta, about how to harmonize the reference interval. So thyroid, as we know, along with pituitary gland and hypothalamus, the level of the TSH. But the functioning of this very important gland has thrown up new mysteries. First problem, normal and acceptable range, upper and lower limits of thyroid function test in particular population, debated in different scientific fora. Standardization still a formidable challenge due to lack of proper reference interval, standardized measurement procedure, like TSH. TSH we can't standardize because there is no primary reference measurement procedure. We can only harmonize the TSH based on all-purpose streamed mean or APTM. Similarly, for FT4, FT3, we can harmonize and then standardize both because there is primary reference measurement procedure. So second problem is clinicians and diagnosticians have to grapple with the variability of test results in itself. Even a broadly similar set of instruments and methods can give up to 40% more or less TSH values. So variation can be to an extent that each individual can seem to have their own set point or these hormones. So maybe we have A instrument in our lab and B instrument in our lab. So we see 10 to 40% variation in the TSH values. So next is, this is runner died in Vadodara Marathon because of sudden cardiac death. And during the COVID, we have had so many cardiac deaths. So similarly here, for high sensitive troponin I, the decision limit or clinical decision limit, so different cutoff for Indian male and Indian female. So that's very important. And also rule in and rule out procedure, giving the reference as a rule in and rule out cutoff rather than giving the reference interval, very important. If you see our reports, we give reference interval. So for that, a reference interval is unnecessary. For that, we need cutoff or clinical decision limit. So this was the genesis of high sensitive troponin I, establishing the cutoff for the Indian male and Indian female. So this was heart attacks going undiagnosed in female in our, we studied in our hospital lab. And at that time, we have seen 14% we were missed when we give the cutoff given or the reference interval given in the pack insert. So because of that, we need to harmonize our lab results. How to do that? So if we see, I believe in the philosophical lines of Albert Einstein, life is like riding bicycle. To have balance, we need smooth ride in our lab life, right? So to have the balance, this balance between these two wheels are very important. What is the wheel of quality? Second is the wheel of cost. Wheel of quality depends on accuracy, precision, validation, verification, and wheel of cost depends on three magic M's: man, machine, and material. So who will do the balance between reference interval, decision limits, then validation and verification? But suppose why this cost cycle also cost wheel also very important. Suppose I have a big lab and I say, okay, I have a test available in my around 450 tests available in my lab. Do you think that will be cost effective? No. So because of that, the genesis of or the importance of today's talk, how to establish, how to define, how to transfer the reference interval for our in-house lab or Indian population. So these are the unmet clinical needs. So why we need to establish. So coming to the reference values, reference intervals. So this is a measured or observed lab test results from a person, usually a patient, compared with the reference interval for the purpose of making a medical diagnosis, therapeutic management decision, or other physiological assessments. So the interpretation of the clinical lab data is therefore a comparative decision-making process. For the decision-making process to occur, reference values are needed for all the tests in the clinical lab, and the provision of reliable reference interval is an important task for clinical labs and diagnostic test manufacturers. The reference values, most commonly used term normal values, expected values, have traditionally been poorly defined and certainly not determined by a uniform process. So it is now apparent that it is important to develop reference interval using a more systematic process that takes into account the various influences, interferences of the measured laboratory test results. So coming to the reference interval establishment. So the health associated benchmarks that assist in the clinical decision-making process are defined as 2.5th percentile and 97.5th percentiles. 2.5th to 97.5th percentile established in a healthy reference population. So usually when we establish, we take that criteria. But there are different methods of reference interval establishments. One is the direct method. It involves recruiting healthy subjects into a study in which samples are collected for the sole purpose of determining a reference interval. And indirect method involves using results of database from your lab data, lab HIS, lab LIS, and hospital HIS. So from that, we have maybe 50,000 patients we can gather, and we can have from 5,000 to 50,000, we can generate the indirect method of reference interval. IFCCC, our ideal committee for reference interval and decision limits, are working on establishing of indirect method of reference interval. Now coming to this, when we established that task force for ICMR reference interval and for Indian population, we thought which methods do. There was like in a discussion, should we go for the direct method and indirect method? Then we realized for the ethnic variation of the Indian population and also for because more common method and more established methods are direct methods. So for Indian population reference interval, And we actually are going for the direct method. So what is the difference between these two methods? Direct method are more robust and accurate, but here we have to think about the cost and resources. This is the disadvantage. And also many times we need ethical restrictions, like, ethical committee. If it is multi-center study, we need ethical committee approval, MOU from all over India, and also the ethnic variation between the Indian population. And when we come to the indirect method, because this is a data mining and maximizes, we get the maximizes volume, but is it accurate? And also the minimizes the cost, because we are getting the data from the LIS or HIS. So this is a difference between two methods, direct and indirect method. Now coming to the different errors we face in reference interval or clinical decision limits. Clinical decision limits are determined based on clinical outcome studies prefer to population reference intervals. So decision limits are available and must be used for like HbA1c. Lipids. Lipids recently, Lipid Association of India guidelines and Cardiology Association guidelines. So lipids, decision limits are important. Vitamin D, ferritin, and some others, HS troponin I, based on the latest clinical guidelines. The common source of error is application of the reference interval in result interpretation when decision limits are more appropriate. For some analyzed, reference intervals have been replaced by decision limits established by national and international consensus. Example, consider the cholesterol, glycated hemoglobin, so like cholesterol and LDL. So you will, in recent guidelines, you will see they are risk stratified and they are giving the guidelines for the, based on the risk stratification, very high risk group, moderate risk groups, like that we are giving, not that in CP-ATP3, we are giving the reference interval. So manufacturers should ensure their methods are traceable. So in practice, very few labs perform their own reference interval study. So for establishing the reference interval, so what CLSI say? CLSI says that we need, if it is following Gaussian distribution, we need minimum 120 samples. Also, we should consider about sex, age range, and inclusion and exclusion criteria. Many times what we do, we just take healthcare, executive health checkup samples or pre-employment samples. We consider that as a healthy population. But we should, whenever we are establishing reference interval, we should have proper reference interval exclusion and inclusion criteria. So similarly, often if or any study done, fewer individuals are used. Like when we are 60 based on availability. So CLSI T28A3 says if it is following Gaussian distribution, we need 120. Suppose it is not following Gaussian distribution, we need minimum 200. And if FDA, when we wrote about TSH reference interval, FDA suggested that we should take minimum 600. So sometimes like electrolytes. So instead of performing new reference interval, lab and manufacturer can any times what we do, we don't consider the updated version of the reference interval. We since long we are using maybe ADA 2006 or Thyroid Association, whatever is given in the old textbook or teeth textbook of clinical chemistry. I have done that for pregnancy reference interval. I have taken from the textbook of clinical chemistry and given the wrong reference interval for the pregnant female. So we need to be very conscious about what reference interval we are referring to. So a CLSI working group is working on that. So they recommend you can, in a small lab or medium-sized lab, even in the big lab, you don't need to establish the reference interval in 120 or 200 population size. we can verify that in 20 samples and with exclusion and inclusion criteria. So for verification of reference interval, we need minimum 20 healthy individuals. So if we see a reference individual comprise a reference population from which is reference values that characterize reference from which it is calculated. So we calculate interval. So this is the flow chart for reference individual, reference interval. So who are reference individual? A person selected for testing on the can you hear me?
Now, yes.
Now we can hear.
Yeah.
Yes.
Now we can see you.
So when it got cancelled?
Ma'am, your
Just
slide.
2 seconds back.
Hello?
Just 2
Just
seconds
2
back.
seconds. Okay. Sorry for the inconvenience. Actually, my father had stroke. So because of that, I have to cancel. So I'm really sorry for this technical
It's
glitch.
absolutely fine,
So
Dr. Barnali.
I'm feeling bad. So, okay. So I think I have spoken about this reference individual. This slide you have gone through, no?
Yes, the
So
next slide.
our
Yes, now from
reference
here.
individual, reference population, and reference individual comprised of reference population and then reference sample group. And we get the reference values that characterize references and reference limits and reference intervals. So reference interval, a person selected for testing on the basis of well-defined criteria. It is usually important to define the person's state of health. So the following a priori application of the criteria before the collection of the sample and the posteriori application of criteria after the collection of the sample. And reference interval is the interval between, as I have mentioned, two reference limits. So this is designated as the interval of values from the lower reference limit to the upper reference limit. So defining the reference interval. So there are few terms like defining, establishing, transferring, and verifying the reference intervals. Defining is like we take central 95 percentile, apparently healthy men and male and female, and between ages 18 to 65. So that is defining reference interval. And establishing or determining reference interval, the process used in creating a reference interval de novo, encompassing all of the steps from selection of reference individuals the analytical method and conducting with data collection and analysis. So that CLSI documentation of C2 that 120 in Gaussian, and if not Gaussian, 200. May
Got disconnected. Kindly check. No voice.
verifying a reference interval. So this is in the 20 healthy population size. So we can verify the reference interval. So several variables. So with like JCTLM, Joint Committee for Traceability of Lab Medicine, analyze for which an official reference measurement system should exist. Like for TSH, we have the secondary reference measurement system for FT4 and FT3. So we should have that. So the possible, when we do multi-center clinical reference interval study, so we should take the common set of reference interval for the multi-center effort, and we should perform a multi-center reference interval study in the following criteria like priority selection, number of the participating centers, race, and clear definition of the pre-examination phases and demonstration of the testability of the results and interlaboratory standardization, ideally by inclusion of two fully commutable reference material or frozen pools with target values assigned by reference method. Because before starting the procedure, we should know that there is harmonization between the interlaboratory measurement procedure. So this part is extremely order what we are doing. The individual lab and then has only to verify this reference interval in its own environment. So like defining reference intervals as CLSI, IFCC. So the health associated reference interval and pregnant, premature, hospitalized, newborn, we should have the reference interval. Now, other terminology, other statistical cutoff like troponin, 99th percentile of the healthy population. So we take 99th centile of healthy population for establishing the troponin cutoff. Then apolittle, 80th centile of the total population. We don't go for here other population. Then recommended reference interval like for impaired fasting glucose, we take ADA, LDL, Cardiac Association or Lipid Association of India, you can take the target LDL concentration. Then therapeutic interval, drugs, INR, APTT. So current protocol, what we use, the CLSI, or ADLM or IFCC based recommendations and repeated in product information from most reagent pack insert encoded in ISO IEC guide 17025. And so this is generating the new reference interval, define and select the reference population, define collection condition and numbers, collect samples, analyze samples, perform statistical evaluation and put it into practice that. So source, so this already I have said about CLSI protocol. We should measure into verification protocol 20 samples. And if two or fewer are outside proposed limits, then we accept that interval. But suppose more than two is outside, then we do in another.
Ma'am, to save your bandwidth, you can switch off your camera. That will save your internet.
Video.
That will
Yes.
save.
So this is yes. So this is because Sunday, there is some challenges, technical glitch I can't call also. So this are different health-related sample group or disease-related sample group. So this relies on the clinical knowledge. So as I have mentioned about the indirect strategy, already I have mentioned. So we can get the data like, 50 to 450 patients for parametric. So here we 120 to 700 patients if we are using non-parametric method. So let me go an indirect strategy, as I have said in LIS. So suppose we are going to, we have come to Goa. So going to the, for coming for conference. So which pilot you will choose, the first one or the second one? Of course, we want to land on the runway, right? So if you see, first pilots also runs, lands on the runway. But if you see the variation, so much variation. And if you see the second pilot always near the target. So our clinicians, our patients, they are not bothered like which wasteguard rules we are applying for internal quality control and other specification. Is it reference interval or clinical decision limits are we establishing or transferring? They want their values should be near target. How do our process looks? It's our diagnosticians or lab personnel duty. So because of that, we need to standardize and harmonize our protocols, our parameters, our methods, technology traceability, commutability, then test requesting, sample pre-examination, and post-examination, and post-examination, like how we are reporting test names and units, reference interval, critical values. So this we need to standardize and harmonize. So this is our paper, like harmonization of serum thyroid hormone measurement for uniform reference intervals. So this is the IFCC's work. So they have established in 14 to 15 essay, and these are different essay specific reference interval. And this is for FT4. And so if you see before calibration, how much deviated it is, and after calibration, so this is standardized. And this is for the FT4 assay, again for the reference interval and different. So this, when we start establishing or verifying the reference interval, so this is the verification criteria, accuracy, precision, then reference interval, then LOB, LOD, linearity verification, extended measuring interval, and lot-to-lot verification need to establish. So this is our study. So this thyroid, I mentioned previously also, the thyroid fairy met this pregnant woman, and she's saying, oh, you can see me that your results are too low. So this is like, you know, we establish the reference interval and reference like informations, gender, female, if they are using contraceptives, inclusion and exclusion criteria. And this is the reference interval we have established for actually 4 different IVD. And I'm sharing one. So if you can see, this is the bootstrap non-parametric procedure. This is 0.49 to 4.67 for TSH, micro international unit per ml. And this is by the parametric procedures on the basis of the power transformed value, 0.45 to 4.55. And manufacturer range is 0.4 to 4.5. So if you can see the variation between the bootstrap non-parametric and parametric procedures and manufacturer's reference interval. So because of that, yes, data, and data. I can't make bricks without clay. So yes, when we talk about reference interval, this is true that data is very much important. And this is, again, one case study. I will show why this is important. This is a 55-year-old female, sharp retrosternal chest pain, resolved within 30 minutes en route to hospital, clinical examination and ECG unremarkable, smoker, but no other risk factors noted. Initial high sensitive troponin I was 9 nanogram per liter, and then the lab used the reference interval. So the lab used the sex specific reference interval, and female it has given 60 and male it was 28. So based on the reference interval criteria, the patient got discharged, but within few hours, within few 30 minutes, patient came back, rushed to the hospital, and the serial sample was 20 nanogram per liter. So what you will see here from 9 to 20. So delta check, it's doubled. So then patient was diagnosed acute MI. So because of that, it is very important when we are giving the lab personnel, when we are giving the reference interval or clinical decision limit, we use the appropriateness of the reference interval or clinical decision limits. So like total imprecision, less than 10% coefficient of variation at 99 percentile is important. Why is detecting more than 50% of the normals above the LOD important here in case of high sensitive troponin? So we are using the total imprecision at the 99 percentile value, less than 10% CB, and measurable concentration below the 99 percentile should be attainable with an assay at a concentration value above the assay's limit of detection for at least 50%. So this actually captures the idea of 95% of the healthy individuals. So because of that, we have done this study in 1607 male and 1134 female. And we have seen when we are using that Parkinson reference interval, the 14% of the female underdiagnosed without the gender-specific cutoff. So this was our study. So the limitation of any immunoassay standardization, cross-reactivity, heterophile antibodies, hook-or-prozone effect. So we should be very careful about that. So biotin interference. So whenever we see any limitation, we should contact the lab. And this is our team. And this is our acknowledgement of the mentors who have done the reference interval study. And so if we see the clinicians are diagnosing the case, so this case of the acute coronary syndrome or acute MI. So but if you see the hand, extended hand, that is ours. We diagnosticians, we lab personnel, we are playing that significant role. So this extended hand for evidence-based medicine or patient safety, so this is ours. Thank you.
Thank you, Dr. Barnale. Thanks to you on behalf of everybody here. Very well articulated presentation. And I do not know whether the questions can be... Yes, please. We have some queries or appreciations. Over to you.
Is observation. I am a doctor specialized in hematology, but I want to make two comments. In my opinion, when I see reference values of the results that come to me from the laboratories, I found one error that for me is important. For example, the reference values for ferritin. Why? Because I think when we are doing reference values, we don't have to only apply statistics. I think it's expensive, I know, but if we want to be accurate, we need to include the more common causes for low ferritin and the more common causes for high ferritin, a part of the liver disease. And I found that for me, the reference values of ferritin have to be minimum value 22, 25, and the maximum value 100, not 300. And why people is reporting the reference values of 300? Because hereditary hemochromatosis is 1 in every 8 persons. It's the more common genetic abnormality. And when I was studying people with ferritin more than 100 without any liver pathology, I found that many of them, 90% of them, have any heterozygous or homozygous hereditary hemochromatosis gene. In the low level, the same. 15% of women between 12 and 13 of hemoglobin have iron deficiency. It's called latent iron deficiency. They are going to develop anemia because the red cells have a medium life of 4 months, but they are not yet anemic. But if we consider women in a child-bearing age, and we include it because they are working, they feel a little tired maybe, but they are okay. But we can make a bias in the values. For this reason, we need to include also clinical aspects, not only statistics, to decide to put a cutoff in the reference values. The second question or observation is that sometimes I see now that reference values are changing in the time. Lymphocytes. Now, some laboratories begin to report normal value of lymphocytes more than 800. Many of them 1,000, and 1,000 is abnormal, and 800 is very abnormal. But what happens after COVID? COVID has provoked immunodeficiency in many patients, and people that coming back to the work after a mild COVID, but they have lower lymphocytes than normal. We don't have to change the reference values. If the values change for the majority of the population, because we need to find a reason for that, because maybe many people have immunodeficiency. And that is the situation. I think there are two aspects as a clinician that we need to consider, not to change reference values in the time, without a very justified and clinical examination of the problem. Also, D-dimer. D-dimer has increased now after COVID area. Why? Some people say it's the vaccine, some people say it's the COVID, but we cannot change the values of the dimer reference values because in the time they increase for any reason that maybe we don't understand or we don't know. But there are two comments I want to do. What is your opinion about these two observations?
Yes, Dr. Barnali, you would like to make any
Yes,
comment?
like for ferritin, you mentioned, and others also. So here, ferritin, most of us are giving the biological reference interval. So ferritin, we actually, the CLSI recommends to give the clinical decision limits. So as you mentioned appropriately, so if some parameters like I mentioned about high sensitive troponin, if we don't give the negative predictive value and positive predictive value, the rule in and rule out criteria in those cases, so many cases are missed based on the reference values or reference interval. So because of all those parameters like ferritin, D-dimer, high sensitive troponin, clinical decision limits are much more important than the giving the reference interval. Thank you so much.
Any other person who would like to ask anything before I make a comment?
Any other questions, please? Yeah, Dr. Deepthi?
Okay.
I think no.
Okay. I have. Thank you very much, Barnali, for good narration. Thank you very much,
Thank you,
Professor.
sir.
I tell you something. Establishing referral ranges, biological reference intervals, clinical decision value is an expensive process. It involves a lot of money. You have to pay the volunteers also who come. It is not easy, but it can be made easy. I tell you how. In a country like ours, biggest democracy, in a country like India, do you know how many clinical availability, bioequivalent, and these clinical trial centers are there? You will be shocked to know. As on today, we have 75,000 such centers. What do they do? Some drug testing, trial 3, level 3, but for which they are taking volunteers, healthy volunteers. They get 100 people, 50 people are rejected, remaining healthy 50 are taken. On the average, each clinical trial center, every year, they have something like for each trial, 20 to 100 people. You said correctly, 20 minimum, 100 maximum. We don't need 300. In a year, you multiply 75,000 multiplied by 50. Huge number. Data is already available for last 30 years. Over a period of 30 years, any changes are there. They are also recorded. They're all available. If only Government of India collects this data, retrospective data of healthy individuals on various renal and liver and other parameters, few statisticians are enough to arrive at biological reference intervals in Indian population. I had suggested this to our health minister, Mr. Nadda. I'm sure he's taking it up seriously. Already letters have been sent to clinical trials, bioavailability centers to share the data. It's Indian data. They cannot say we cannot share, though they have an agreement with several pharmaceutical companies that they will not share this data with anybody. But if an Indian government can get this data and take the help of people like Barnali and other statisticians, I'm sure we have a very reliable Indian population biological reference interval can be established without much money spent on this. This is one suggestion. The second thing, should these laboratories be accredited as per 15189 was a question. No need. If they are complying with good laboratory practices, if they are using good instruments and equipment like from Mindray, I think that is more than enough. Thank you very much.
Thank
Good
you, sir.
morning, Dr. Barnali. There are few questions online also. One question is, do you recommend indirect method as a standard process? if it is validated by 20 samples?
Indirect method now, like IFCC, CIRIDL, they are actually working on the indirect method. But here, like if it is validated by 20 patients, so the validation, the 20 patient validation criteria is very small. So taking indirect method in that is little bit difficult, but based on the statistical evaluations, because indirect method caters huge population size. So with that, with exclusion and inclusion of the refiner is one of the tools for establishing indirect methods. So if it is we give the appropriate volume, so I think it can be done. So
Thank you, Dr. Bhandari.
actually here the question is, he tries that verification of reference interval by 20 according to CLSI C28. And suppose that if we can then gather the lab data and use the indirect method of establishment of reference interval. Yes.
Thank you,
Ma'am,
Dr. Bhandari.
more
There is
questions?
one more. Yeah.
Yeah, ma'am.
Another question is reference
someone is
interval in
asking-
machines and reports.
Ma'am, someone is asking what are the potential risk and limitation of using indirect method and how these can be mitigated, and what should be the frequency of indirect method revalidation to ensure accuracy? Ma'am, can you please?
So indirect method, like when, let me tell you that, as sir mentioned, that also like clinical trials companies and ICMR, when we started this journey of establishing the reference interval, so we actually considered both indirect and direct method of establishing the reference interval. Like I mentioned the disadvantages of the indirect method. So of course, yes, there is a huge sample size, and the cost effectiveness is also there for the indirect method. But most times, so it's like for Indian population, if we want to establish the reference interval for the first time, so then we should go for the direct method rather than indirect method. But suppose we want in-house to know, like in-house reference interval, so we can take the direct strategy, and that annually the verification should be done, the method verification and the establishment of reference interval.
Thank you, ma'am. Thank you.
Any other online questions? Nikhil? Madam?
Actually, there are many other, but repetitive, so I'm not asking. So we can move.
Okay. Okay,
Okay,
fine.
thank you so much. Thank you. And I can see so many people, so many, I'm really honored. Thank you.
Thank you, ma'am. Thank you so much.
Thank you, Dr. Barnali. God bless you. All the best.
So may I request, we will show you your memento. I'll just carry it to Mumbai when I'm back. So may I request Dr. Venkatesh to hand over the memento to our speaker?
Thank you, sir. Thank you, sir. I'm really honored. Thank you. Thank you. Thank you, sir. Yes, sir. Yes. Thank you, everyone. I'm truly honored, and thank you, Mindray.
Thank you, madam. Thank you so much. We really heartfelt thanks.
Yes.
And
I'm sorry for the technical glitch. I'm really
it's
sorry.
okay. It's absolutely fine. So you'll be online for the other lectures?
Yes, yes.
Okay. Thank you
Thank
so
you.
much. Bye-bye.
Bye.
So moving on to the next session, may I request Dr. Susruta to please come on stage? And I had a special request from Dr. Ramon that he wants to chair this session because he's a master in autoimmune. So, yeah. So, Dr. Ramon,
Yes, welcome to Dr. Suruta Sen. He is an expert in biochemistry and diabetology, and he is the President Association of Clinical Chemistry and Lab Medicine Practitioners, Central Committee, editor of GABLM, Journal of Applied Biochemistry, and also is an NABL lead assessor and former CAP international inspector. He published some various research articles and actively participated as guest speaker in many national and international conferences. The floor is yours, Dr. Suruta.
Thank you. Was it on now? Yeah, fine. So actually, you see, I'm carrying a bottle of water when I'm coming on the ice because I was given this to deliver a lecture in a pathologist conference, a role of biochemistry in autoimmunity. So I thought that might be very little one. So I was preparing. I actually it's opened the entire world in front of me that probably nowadays in all autoimmune diseases, the biochemistry has got role is almost in 99%. Because previously what we used to think that an autoimmunity means immunofluorescence, pathologist role, and everything will know about IFA and everything. So now, more we go for this talk, I can find that the huge area of autoimmune diseases can be diagnosed with immunoassay and biochemistry alone. So that's why it's a huge one, and I have to gallop within 20 minutes. So it's a tough thing, and I would like to start it. So this is what we call an autoimmunity. We call it to brute. That's our own or body own immune system as actually is going to endanger our life, and that is why this is being very difficult. And let's see how our body tackles with it. So these are autoimmune disease possible cause and risk factors. I'm not going imitating, just giving it in repetition. You can go through common things. So when the pathogenesis of an autoimmunity, autoimmunity can be of a neoantigen formation, can do a molecular mimicry. That means when sometimes a microbial antigen is actually mimics like an own antigen, and therefore the antibody develops in our body, reacts on our own body antigen, body proteins or materials. So then the release of the sequestrated or cryptic antigens, the polyclonal B cell activation can be a reason. Super antigen can also be another reason. And yes, the cross-reacting antigens, when a native antigen cross-reacts with a foreign antigen, and therefore you can have an autoantibody developed in your body. So, how strong is the defense? That is most important criteria. So, in this defense, we have a central tolerance and a peripheral tolerance. So central tolerance means when you have a immature lymphocyte, and if that immature lymphocyte can recognize any of your body protein, any of your in-house protein, and therefore this one goes for a negative selection. So and this one which do not have any specific target of your own body antigen, it is actually getting matured. So therefore, in this during the selection centrally, we actually nullify those autoimmune antibodies to develop right from the beginning. So therefore, the peripheral tolerance, it can be developed after autoreactive T and B cells enter the periphery after maturation, or maybe suppression by the T regulatory cells, absence of co-stimulatory molecules, which is called energy, immunologically privileged sites and anatomical barriers. What are those things? These are like the lens proteins and the testicular proteins. They have a barrier from blood system, so immune system. So immune system never recognize them, and therefore it's always a foreign body to them. So therefore, anytime it comes to the immune system, it's a foreign one. So antibody immediately develops, but otherwise, whole lifelong, they becomes privileged site and they have anatomical barriers, so you don't have an antibody developed for it. And sometimes a very low antigen concentration, which does not create that much of a problem because of its low concentration. Now, we have a classification of autoimmune disorders, can be organ specific, can be system specific. For understanding, I have made it in this way because there are always overlapping of this autoimmune disease on one another. You cannot have that much pinpointed always. So these are the common things. These are common we actually come across. These are autoimmune hemolytic anemia, Addison's disease, good posture syndrome, Graves' disease, Hashimoto's thyroiditis, ITP, insulin dependent diabetes mellitus, or myasthenia gravis. These are all organ specific. That means that immunoactivity is mostly related to one organ or one system, which therefore is a specific in that account. So there are certain things which are systemic. We have the multiple areas of involvement. These are Angstborn multiple sclerosis, rheumatoid arthritis, scleroderma, Jorgen syndrome, SLE, and so many things. So they have a systemic involvement, having multi-organ involvement and multi-sectoral involvement. So this is our armory. This is what the arsenal, I should say. Indirect immunofluorescence, immunofluorescence assay IFA, competitive indirect ELISA, CLIA, ECLIA, and immunoblot and dot blot technologies are in majority. These are the technologies we use, but there are other advanced technologies also, which is a modified version of CLIA or ELISA. So we'll come across. This is the maze where we have to go through, and this is how we actually like to go to. The common and predictable offenders, particularly in our country, mostly in our Southeast Asia, these are the things we commonly encounter with anti-CCP, ANA, anti-dsDNA, ANCA, anti-TPO, anti-TG, etc. So, the biochemist and vigil, the anti-CCP and ANA is a hallmark of SLE. Anti-dsDNA, as you know, is a very crucial to diagnose of SLE. And all other things, these are the specific immunological markers which can actually uh, detect, clarify, or detect pinpointly to one particular disease. Now we go with this. These are more or less 18 or common autoimmune disorders that we encountered in our country, in this region mostly. So I'll talk about mostly on those because these are in immense in numbers. So I cannot keep everything in list. So those are most common things occurring in our countries. Anyway, it's not working for me. So we go for organ specific autoimmune disorders now. So this is what first I talk about the myasthenia gravis. So I'm actually talking a bit slow. I should be more faster. So myasthenia gravis, as you know, is a prototype muscle skeletal muscle problem. So what happens here? It is the acetylcholinesterase antibody, acetylcholine receptor antibody that develops in these disorders. So it actually destroys the acetylcholine receptors, and therefore the skeletal muscle weakness gradually goes on, and it starts with the eyelids, and later on all other muscles gets affected. And the most common diagnosis here is with this. We have this acetylcholine receptor antibody, which can be detected through this radioimmunoassay RIPA, which is a gold standard method, which use iodine 125 alpha bangarotoxin, which is a very highly specific antagonist of this acetylcholine receptor. Next, I think it's not working. Can you please? Next is this autoimmune thyroid disorder. So, in case when we talk about the autoimmune thyroid disorder, mostly we talk about two things. One is Hashimoto's thyroiditis, and second one is a Graves' disease. In Hashimoto's thyroiditis is basically what is the thyroid is an antibody develops against the thyroid. Is it working? Okay, fine. So in case of Hashimoto's thyroiditis, you will get an antibody development against anti-TPO. That is, and the thyroid peroxidase is actually the rate limiting enzyme of the iron, I think, thyroid thyroxine formation. So you will get an antibody against TPO commonly, and anti-TG antibody also develops in 90% cases. So it is not only present in Hashimoto's thyroiditis, but is also very much present in Graves' disease as well. So the thyroid specific, this one predictability is pretty high with this Hashimoto's thyroiditis. And I'm going against, sorry. So in Graves' disease, you will get another antibody, which is TSH receptor antibody, which can be a stimulatory event and inhibitory event sometimes. So mostly it is stimulatory. So that is called TSAB, thyroid stimulating antibody. So that actually releases huge amount of thyroid production, increases thyroid production, leads to a hyperthyroid status of the person. Sometimes it can also have a blocking antibody, which may lead to a hypothyroid status, but that less common. More common is this hyperthyroid status, and they can have a switching effect also. So that is in a pinpoint. If you want to go for a Hashimoto's thyroiditis detection, you have to have an antibody with anti-TPO and anti-TG. And for Graves' disease, anti-DSAB antibody is a very important one to be detected for diagnosis. Now, this is one a type 1 diabetes mellitus. As you know, in a type 1 diabetes mellitus, you have an antibody develops against the islet cells of Langerhans, those which are producing the insulin. So the islet cell antibody is very important marker of this IDDM. Apart from ICA, you can have anti-GAD65 and also the zinc transporter or ZN18 as well. Now, the most important thing, why it is important? It is important because the antibody has developed right from the beginning for a baby. So if you detect the antibody, so there are certain phases that this is the normal phase, but still there is an antibody developed there. And this is where the islet cells are getting damaged, starting getting damaged. This is where a significant damage is there, and already there is a hyperglycemia. And this is the condition where most of the times you get the baby with actually a diabetic ketoacidosis, a severe condition of hyperglycemia. So the advantage of this autoimmune disease, advantage of this detection of islet cell antibodies and others is that even before going to hyperglycemia, you can actually treat the patient right from the beginning. So if you start treatment on this process, you will never get a DKA baby to treat on. You will get a potential IDDM baby to treat on. So therefore, it can reduce mortality significantly in this case of the pediatric population. So next in Addison's disease. This is in the adrenals, as you know. Addison's disease is also an autoimmune disorder. So therefore, it is detected with, there is so many features of Addison's disease add on, because usually one autoimmunity usually carries on with all other things as well. And there are other things like sodium, potassium, and all these things all get deranged in Addison's disease. But to diagnose, principally, we need to have a antibody to develop. So this is a 21 hydroxylase antibody. That is a specific antibody for the Addison's disease diagnosis. So apart from this, you can also have this as, these are all biochemistry tests which actually helps you to come to a diagnosis. These are plasma renin activity, ACTH, and baseline cortisols. So as you know, with the disease, the baseline cortisol goes down and all other things with ACTH as well as and plasma renin activity counter reacts on the low cortisol levels. But at the end of the day, whether it is a adrenaline disorder or it's an Addison's disease, you have to have a diagnosis only on basis of 21 hydroxylase antibody detection. So therefore, this particular autoimmunity can be detected through immunoassay only. Now we come to some gastrointestinal disorders. So when I'm talking about some gastrointestinal disorder, so these are celiac disease, IBD, and primary biliary cirrhosis. So in case of IBD, we have mostly Crohn's and ulcerative colitis, very commonly present in our uh, country. And particularly, I like this disease, ulcerative colitis. I don't want to be a patient, but I like the disease because whenever somebody challenges me, can you specify even one particular thing which is protected by smoking only? Smoking is so bad. I always say this one is protective for smokers. So ulcerative colitis is the only disease I came across throughout the day, which actually for smokers it is protected. So anyway, so uh, this all other gastrointestinal disorders. Many of you are frowning why I'm studying this actually. So the good role of smoking, if you find this is the only one disease which can give you some positive points to say about it. That's what I'm saying. So anyway, the celiac disease. So the celiac disease, as you know, you also know this is a small bowel villus atrophy, and therefore it actually leads to a gluten-induced enteropathy. So they are intolerant to the gluten diets particularly, but this actually can be diagnosed with diagnosing this anti-TTG antibody. And the advantage is that, very important advantage is that even right from the onset, if I can detect this anti-TTG antibody, and I know that this person is a going to have a gluten-induced enteropathy, I can restrict the diet from the person's gluten from the person's diet, and therefore the celiac disease does not at all appear in a very acute stage. So therefore, these are the conditions which can preemptively diagnose, and we can actually have a cure of it. Honestly, this is if you withdraw gluten right from the beginning from the diet, you are not going to encounter this celiac disease at all. Then other antibodies, the very defective things is that Crohn's and ulcerative colitis more or less having a similar kind of feature. There are differences obviously, but what the best thing to do is an invasive diagnosis. You have to have some colonoscopic biopsy to get the right result on it. But you can also be detected with this autoimmune assay that therefore the antibody, the ANCA, anti-neutrophilic cytoplasmic antibody or ANCA, another one is anti-Saccharomyces cerevisiae antibody ASCA. So therefore you will find ANCA more in case of ulcerative colitis and ASCA more in case of celiac disease. So therefore, you can actually differentiate the two diseases without being invasive in your diagnosis. That is a big relief for a patient like in inflammatory IBD patient. Doing a colonoscopic biopsy is extremely painful. So if I can diagnose it through my blood sample only, that gives a huge relief to the patient as well. So this primary biliary cholangitis or primary biliary cirrhosis, as you know, if you can detect an anti-microchondrial antibody or anti-AMA, this is one of the hallmark of the diagnosis of primary biliary cirrhosis. Then all are autoimmune vasculitis. So these are autoimmune vasculitis is a huge one. This is a hugely spreaded subject. So I cannot actually give one shot go with this. So they are mostly we have this ANCA, cryoglobulins, anti-glomerular basement membrane antibody, and anti-C1q antibody. So mostly I'm talking when I'm talking about the systemic vasculitis, as you know, ANCA, which either directed against proteinester PR3 or MPO. So cryoglobulins, which immunoglobulin precipitates in vitro when temperature is less than 30 degrees and 37 degrees centigrade. Anti-GBM mostly found in good posture syndrome, where you will have a RPGN, that is rapid progressive glomerulonephritis, along with pulmonary hemorrhage, because it actually have a immunoreactions in both basement membranes of glomerular basement membrane as well as the lung base also. So therefore, it actually have the glomerulonephritis and lung hemorrhage together. And last one is anti-C1q, which is particularly very evident in case of hypocomplementary arterial vasculitis, who I have no specific idea about it, just got it, so I have given it. So, candidate autoimmune of systemic vasculitis, as you know, ANCA is very much detectable in Wagner's, microscopic polyangiitis, Klokstad syndrome, etc. So there are two things, C ANCA and P ANCA, as you know, cytoplasmic and very nuclear. Anti-GBM is mostly detected by invasive ELISA. Cryoglobulins, then anti-endothelial cell antibody, which is particularly very much positive in giant cell arteritis and Takashio's arteritis. Anti-lysosomal antibody or LAMP2, which is present in renal limited vasculitis. That anti-C1q I said for HOOV, and these are all the things which are commonly encountered autoantibodies for vasculitis, systemic vasculitis. Then hematological disorders, ITP, autoimmune hemolytic anemia, and pernicious anemia. For ITP, you will get particularly diagnosed with this glycoprotein GP2B3A, this antibody. So this particular antibody, if present with the platelets, and the platelets leads to idiopathic thrombocytopenic purpura, where the platelets are destroyed by antibodies. Then autoimmune hemolytic anemia, as you know, it is mostly detected by the direct home test or DAT. So this is what I don't think that you need much discussion on it. This pernicious anemia, another one, anemia which actually leads to a B12 deficiency anemia or a megaloblastic anemia. So what happens here? It is actually having the intrinsic factors, antibody is developed against this intrinsic factors. So therefore, they may create a vitamin B12 deficiency because vitamin B12 does not get absorbed. But this condition is actually having very much I should say confusing with vitamin B12 deficiency. To actually have a pinpointing diagnosis, we have a Schilling test. That's also another biochemical domain. So you have a 51 cobalt. You can ingest those patients. So if it is a only B12 deficiency, B12 gets absorbed and will get everywhere in this excretions. And if you have a pernicious anemia, the vitamin B12, despite of giving vitamin B12, it will not be absorbed and you will not find anywhere in the excreta. So this is a Schilling test which distinguishes between pernicious anemia and the B12 deficiency anemia. Now, if we go with the systemic disorders, I think already everybody is exhausted. I am also. So if you go with the systemic autoimmune disorders, we mainly talk about the SLE, Sjogren's syndrome, rheumatoid arthritis, and other systemic autoimmune disorders, particularly like multiple sclerosis, angstpon, scleroderma, and therefore this SLE first, as we already have talked about it, the most common antibodies that we find in SLE is ANA as a whole with anti-dsDNA, anti-smRNP, and all other things. So usually anti-Rho and anti-La is more common in others, not in SLE, but you can get it. So particularly in these cases, I think pathologists know much more than that, and there is overlap. So although it's a systemic disorders, but the antibodies may have a overlap. So you may get 20 to 30%, you may get anti-Rho, anti-La positive. In Sjogren's syndrome, you will get most of them positive with those. So these are the things as a whole. When you get anti-U1 RNP, you know it is most of the cases MCTD. If it is smooth muscle, most of the cases SLE. So this so on. So therefore, there is a n number of things which is some of the most significant to some, but that does not mean that in another one, particularly suppose in scleroderma, you may not find it. You may find it, but in 20 to 30% cases, it is positive also in other disorders. So there are lots of overlap. Only a very connoisseur of this disease diagnosis, they can only actually pinpoint a diagnosis. Otherwise, I find it is always very confusing when I deal with these kind of things because of this extreme overlapping of this antibody with one another. Now, therefore, the Sjogren's syndrome, as I was telling you, that mostly will find that anti-Rho and anti-La antibodies are particularly present in these cases. But you may find anti-CCP antibody as well, which may confuse it with rheumatoid arthritis. As you know, anti-CCP is more specific for diagnosis of rheumatoid arthritis. As I was talking to you, that this mostly will get anti-CCP antibody, which is the most one for detection of this rheumatoid arthritis and also rheumatoid factor as well. But you may get a rheumatoid factor negative rheumatoid arthritis in many cases. So this is as a whole a very difficult Bermuda triangle. I don't want to get into it. So then the multiple sclerosis, this is particularly a central nervous system problem. So therefore, you will get this as a pinpoint diagnosis. Anti-myelin based protein or anti-MBP and oligodendroid specific protein antibodies. So if you detect any one of them, you can have a very easy to diagnose this and this multiple sclerosis in those cases. Angstpond usually don't have any specific antibody, but mostly associated with HLA-B27. Whenever there is an HLA-B27 positive, as we have got a 96% association of HLA-B27 and Angstpond, so that can give you some kind of help with your clinical diagnosis. But most of the cases, I am talking about the systemic diseases, the diagnosis mostly clinical, where a role of biochemist is to support your clinical decision. The same of scleroderma. So just this, I think I have finished more or less within time. A bit, I have probably overshooted 5 minutes. So in conclusion, so autoimmune disorders are numerous. So trying to give a speech in 25 or 30 minutes is a crime. Then detection modalities largely was invasive. Now with this significant progress in the biochemist assay, particularly of immunoassay, we are gradually going for a more non-invasive diagnosis of those tests, particularly, and that is the goal. So you can have a reliable diagnosis, non-invasive diagnosis, very important, because a person never wants to have a bypass or invasive kind of technologies to be adapted. So if somebody gets a blood sample detected for MI, nobody would have gone for an angiogram. That's a very common thing for everybody. So, and also it is important for disease monitoring and disease prognostication. So these are my references, and thank you for patient listening.
Thank you very much for your wonderful presentation. Somebody have any question?
Recently, we had two patients with very high rheumatoid arthritis value. The anti-CCP was negative. Like, is it possible to have that?
First of all, rheumatoid arthritis, RA factor negative arthritis is possible, positive arthritis is also possible. Usually, anti-CCP correlates very well with this rheumatoid arthritis. But at all, if you get some anti-CCP negative, but still clinically very significant with the rheumatoid arthritis, you have to treat like a rheumatoid arthritis at the end of the day.
In
So
spite of being anti-CCP negative.
maybe anti-CCP is very unlikely, but yet if your clinical diagnosis goes for rheumatoid arthritis, then you have to treat that patient with rheumatoid arthritis.
Thank you.
Any other question? I have a question for you.
Sure.
And in 2022, one article from China said that in 4 million people, that people passing COVID have 3 times more frequency of autoimmune disorders. Have you seen from 2020 an increase of autoimmune disorders in your lab?
I can't get it. Can you please?
Yes. In one article in China, was published in 2022, they described that during COVID, they studied 4 million people. 900,000 have passed COVID, the rest no. In the group of COVID, they have 3 times more autoimmune disorders. My question is, have you seen an increase of autoimmune disorders in India in people that have passed COVID?
Rather, I should say that there is a small one, but yet I am having a definite idea that in COVID particularly, the autoimmune disorders, the patients who are having autoimmune disorders,
No,
where
the opposite. People that have past COVID after they have more autoimmune disorders.
obviously, again, I'm saying that COVID, what does it do? What actually goes a cytokine burst, and actually the cytokine storm, that was the main cause of the death of those patients. So, and all these autoimmune disorders, they also at the same time ultimately cause some amount of cytokine rise, isn't it? So, sometimes it is possible that COVID might have increase that particular pathway, the cytokine release pathway or the immune modification pathway, which can, and obviously I have seen a few patients with autoimmune, as you are very rightly pointed out, there are chronic autoimmune patients, but the upsurgence of this autoimmune disorders, or rather I should say the uh, uh, clinical manifestations of the autoimmune disorders suddenly has raised after COVID. That is obviously what you are saying. I do agree with that.
Okay.
I have seen the same.
And the second question is, have you seen a special personality in the people with autoimmune disorders? Because treating many patients with autoimmune, in my case, I have seen that they are perfectionist and self-criticist. Have you seen any special personality in the people with autoimmune disorder?
Sir, this is very common. This is very common. When you know that your own system is against you, and day in, day out, you are fighting against your own system to keep yourself healthy, you have to be very perfectionist, and you have to be very critical about yourself, because you become very open in that time. A person with is actually filled with his ego is unable to take a criticism, but a person when he feels from within that it's my own system is my enemy and I'm right, from day in day out I'm fighting against it, I think it opens up that window so that you have more self criticism in it. So that's my personal belief.
Okay, thank you so much.
Thank you. Thank you.
Thank you so much.
Thank you. Thank you, Dr. Ramon. Thank you, Dr. Susruta. So moving on to the next session, may I call Dr. Sarmishtha on stage, please? And may I request Dr. Susruta to chair the session?
For the previous, it's working now. Thank you.
So it's a privilege to introduce Sharmishta Chaudhary for this session. Dr. Sharmishta Chaudhary is assistant professor, Department of Biochemistry, Arjikar Medical College and Hospital. And she is AGS of my association, SCC LMP, West Bengal chapter, and also a very integral part of the journal, JBLM, that is the official journal of SCC LMP. And she is technical assessor of NABL since 2022, attended many conferences as guest speaker in CME and conferences, and basically the one of the powerhouse of our association. So we welcome Dr. Sharmishta Chaudhary. Topic of her is biomarkers of COPD, which is chronic obstructive pulmonary disease, worth therewith in gold.
Thank you, sir, for this excellent introduction. So this is a topic the reason why it's very much after my own heart is because there is precious little in any of the textbooks, not even in our Bible, the Teach's textbook of clinical chemistry, has a single word about biomarkers in chronic obstructive pulmonary diseases or in lung diseases for that matter. And it's a mystery to me that why this has been ignored, considering the huge plethora of literature which is actually available. So I'd like to take you through this journey. So chronic inflammatory lung diseases, these arise from exposure to cigarette smoke and other inhaled toxins and results from a gene environment type of interaction. The biggest culprit is of course smoking, and clinically it is defined as post bronchodilator. So they give a bronchodilator and then they calculate the ratio of the forced expiratory volume in the first second. It's called the FEV1S to the forced vital capacity, and the ratio classically in COPD is less than 0.7. It affects no less than 10% of the world's population with a close to 3 million deaths and a huge financial burden to the healthcare costs annually that is estimated to be no less than 44 billion USDs. So this is the global picture. It's a fair pandemic and India is not behind. So the origin is multifactorial, and we actually, the need of the hour is a reliable and very accurate laboratory diagnosis, which is able to influence the pulmonologist's therapeutic decisions and which should have a direct bearing on patient care and outcome and should affect the lab efficiency positively. So this is how a healthy lung looks like vis-a-vis a COPD patient's lungs with the blebs and bully. We are all aware of that much from our basic knowledge. Now, the hardest stumbling blocks when it comes to diagnostics of COPDs is that the disease is extremely heterogeneous, quite complex. There are multiple subtypes and the variance is huge and pretty much unexplained. It's often pretty inexplicable. There are frequent ups and downs, frequent exacerbations occur. The disease course is unpredictable. There is a paucity of therapeutic options also, and the mortality statistics as a result are quite unfavorable. So the picture is very, very bleak, very, very grim. But if life's problems wouldn't be called hurdles, they wouldn't be called that if there wasn't a way to get over them. So there is always a ray of hope. So therein comes the emerging role of biochemical markers. So why the necessity at all? I mean, why do we need biochemical markers? Because for long, the FEV1S or the FEV1, which I just defined in my previous slide, that has been considered a gold standard marker for COPD progression. But it is a weak indicator of future exacerbations, long-term decline in lung function, therapeutic efficacy, and mortality. So biomarkers are far more superior. Why? Because number one, they provide much more specific information regarding the disease activity and the underlying pathogenesis. They can reliably distinguish between the slow versus fast decliners. This is very important, very significant, because this has a direct bearing on disease prognostication. And particularly, they are important for the recognition and treatment of the disease in its early stages, which is everyone's aim. The pulmonologist's aim, the patient's aim, everybody wants to get treated in the early stages. Nobody wants to, get treated when they are in their deathbed. So these are the myriad advantages which biomarkers have: their predictive potential, their ability to pinpoint the subgroups, to serve as surrogate endpoints. This is one of the cardinal features of an ideal biomarker. I always beg to differ that an ideal biomarker is defined by its ability to show 99% sensitivity and 99% specificity. Such a biomarker does not exist in practice. It exists only in theory. But what can actually exist in practice is a reliable biomarker which can serve as a surrogate endpoint. This is very important. And those of us who are dealing with biomarkers know by now that surrogate markers are going to be the game changer, unless they already have become game changers, frankly. So to continue, the role in precision medicine, early detection of the subclinical cases, better understanding of the disease pathogenesis, risk stratification, and last but not the least, identification of novel and successful therapeutic targets, what we call tailor-made medicine actually. So this was a study which was conducted in a large number of countries. It was a multicentric study. It is called the ECLIPSE study. It's a very famous study, but frankly speaking, before I was delving into this topic, I had no idea about such a robust study. We have all heard of the Framingham study, but we've never, I don't know how many of you have heard of the ECLIPSE study. So this was a large multicentric study. It is called, the full form of it is Evaluation of COPD Longitudinally to Identify Predictive Surrogate Endpoints. Mind you, this is the second study I have encountered after the study by the American Heart Association, where the study focused on biochemistry and on biochemical markers. Right now, if we know, as per the American Heart Association, the diagnosis of AMI is incomplete, inconclusive, and impossible without high-sensitive tropi, which is a biochemical marker. Similarly, the ECLIPSE study, it was incomplete, and it at its helm point considered the predictive surrogate biochemical endpoints. And it was a non-interventional, observational, multicentric 3-year study where they included 2,180 COPD subjects who were classified as per the Global Initiative of Obstructive Lung Disease, or the GOLD classification, based on the FEV1 is to FVC ratio, categories 2 to 4. That is, those having FEV1 between 50% to equal or less than 80%. Then stage 3 was between 30 to less than 50%, and stage 4 was less than 30%. The equal or greater than 80% is the normal population, so they did not consider stage 1. Plus, they included 343 smoking and 223 non-smoking control subjects. So multiple parameters were assessed at baseline, 3 months, 6 months, and every 6 months thereafter for the 3-year duration of the study. And what did they assess? They assessed so many of these biomarkers, of which we have, apart from biomarkers, see the biomarkers, the font size I have kept highest, not because I'm a biochemist, but because it was the study, those who were conducting the study, they kept it as the highest prerogative. Apart from the biomarkers, they assess the 6-minute walking distance, body impedance, health outcomes, CT chest, resting oxygen saturation, and pulmonary function tests. So what were the candidate biomarkers, which at the end of the ECLIPSE study they identified? They divided them into 4 segments: blood-based, urine-based, sputum-based, and EBC-based. EBC being exhaled breath condensate. So what are the biochemical techniques employed? Mostly all that we have heard of: the classical immunoassays, LCMS, GCMS, electrosensors, slide-based cell counting, and immunoturbidimetric techniques. So we'll go one by one, starting with the blood-based. So these were the 5 candidates that they identified. The first one, of course, is our dear old friend CRP. Then we have fibrinogen, we have SRAGE, CC16, and SPD. I'll come one by one. Now, CRP, we all know, I won't go into the biochemical details because this is all fairly known to us, and the normal levels are usually less than 5 milligram per liter. It is a non-specific, but it is an acute phase reactant protein. Classically, it rises in any acute inflammation. What is important to note is that its half-life does not change between health and disease. So only the production rate changes, not its excretion rate. So production rate is the sole determinant of plasma concentrations. What is its role in COPD? It indicates poor lung function, reduced exercise capacity, and worsened quality of life. And it is raised in stable COPD independent of smoking behavior. So whether the person gives up smoking, continues smoking, there'll be no change. And it is related to low FEV1 percentage, less SpO2, and 6-minute walking distance is also lessened. And it is a strong long-term predictor of hospitalization and death, and correlates very well with IL-6 level, which again is one of the chief inflammatory cytokines raised in most of the acute lung pathologies. Now coming to fibrinogen. Fibrinogen we know is a glycoprotein, and it converts fibrinogen to fibrin, which again converts prothrombin to thrombin, and finally prothrombin to thrombin, it converts fibrinogen to fibrin during any tissue or vascular injury, and then the fibrin degradation products or the D-dimers, those can be assessed. Again, this is a positive acute phase protein. And what is its role in COPD? It distinguishes individuals with COPD from controls at the population level. So this is very important to identify the actual cases. as well as it identifies those who are more at risk and more likely to exacerbate, again independent of smoking status. And it acts as a surrogate marker in signaling the outcome at treatment endpoint. So whether the treatment will be successful or not is often indicated by the fibrinogen levels. And it is an effective predictor of recurrent hospitalization requirements and the ACM in COPD. Pulmonologists are extremely concerned with ACM, which is also known as the all-cause mortality. And mind you, since 2015, the FDA has approved it as the first prognostic or enrichment biomarker for COPD exacerbations. I'd like to point out that an enrichment biomarker is again finding a diamond in the rough, because an enrichment biomarker is actually such a biomarker which the governing body like an FDA has approved for use in a population while a study is ongoing. You do not get to see that too often. Until and unless the study is completed, then the approval comes, then you can use it in the general population. But an enrichment biomarker is kind of an aristocratic biomarker which has been approved for use in a population even while a study is going on. So that has its own advantages. So fibrinogen was an enrichment biomarker which the FDA approved for use while the ECLIPSE study was going on only. The third marker is the soluble receptor for advanced glycation end products, also known as sRAGE. Now, advanced glycation end products, as we all know, those are pro-inflammatory. So this is an emerging biomarker. This is encoded by the AGR gene, and this gene shows a lot of polymorphism. So this is a 41 kilodalton multiligand transmembrane protein. It belongs to the immunoglobulin gene superfamily. Now, cleavage of the extracellular domain of the receptor for advanced glycation end products, it results in two fragments. One is the soluble fragment, which we are concerned, and the other is the membrane-bound fragment. Now, the soluble fragment is a 35 kD protein, which floats around in plasma or serum, and we can detect it biochemically very easily. Unlike its membrane-bound form, this is anti-inflammatory nature. The membrane-bound form, it stimulates a cascade of pro-inflammatory damaging reactions, but the soluble form, the sRAGE, is anti-inflammatory. And since it is anti-inflammatory, it is obviously negatively associated with CRP, fibrinogen, and white blood cell counts. So what is its mechanism of action? It is basically protective. It goes and binds to the advanced glycation end products, thereby preventing the AGEs from binding to the membrane-bound receptor and causing an inflammatory cascade. So it acts as a kind of decoy receptor. And as a result, the transmembrane signaling caused by the membrane-bound receptor of other pathogen-associated molecular patterns or damage-associated molecular patterns, that is reduced. In fact, in the last session, since this context has come up, there was a question that was COVID capable of inducing autoimmune disorders, I think in the last session. And the answer lies here. Because what COVID has done, it has stimulated many damage-associated molecular patterns within the human lung morphology and or within the human body for that matter. And what has happened is those antigens are having a very strong homology to many of our self-antigens. And hence, the robust autoimmune response has occurred in those cases. So similarly, this phenomenon is also happening in COPD patients, and this is countered by the sRAGE because it kind of acts as a decoy, takes up the AGs and prevents it from binding to the membrane-bound receptor. As a result, what happens? It reduces the lung injury and has an inverse correlation with the positive markers of lung damage in COPD. And it is the strongest known inverse associated with emphysema, independent of airflow obstruction and other covariates. Its low levels are obviously associated with acute exacerbation. High levels are predictive of 5-year survival, or low levels are predictive of 5-year progression of emphysema severity. The rise in endogenous levels have been induced on long duration smoking. This is a very dangerous statement to make with chronic smokers because I feel it will unnecessarily encourage them to smoke some more. One can call it a kind of natural immunity, a God-gifted immunity to smokers, which is begs the question that why do some smokers develop emphysema and while others can smoke like a chimney throughout their lives and have nothing? The reason is, again, I'm saying this particular gene is extremely polymorphic. And higher levels or lower levels, as per the golden rule of polymorphism, some smokers will express far more, some will express less. Accordingly, some will be protected more, some will be protected less. Anyway, but statutory warning, please quit smoking. Those who are smokers, I am not one to advocate smoking. This is in no way an advocacy for that, because you don't know to which lucky bunch you belong, or whether you belong to the unlucky bunch. So anyway, so this is a candidate therapeutic agent also. Why? Because it helps in reversing the inflammation also. And this part has been demonstrated only in animal models. Maybe subsequent studies will show that you can give it as a therapeutic agent in humans also. Now, the fourth marker, that is the CLARA, or the club cell secretory protein. These are small secreted disulfide bridge dimeric protein. They belong to the secretoglobulin family. They are secreted by the non-ciliated CLARA cells of the respiratory bronchioles. And again, they are protective against oxidative stress and subsequent carcinogenesis. What is its role in COPD? It also acts as a potential surrogate marker of non-ciliated epithelial dysfunction in lung disease, including COPD, because mind you, COPD is not just of the ciliated population, even the non-ciliated cells are affected. Significantly lower levels have been seen in the serum and the bronchoalveolar fluid lavage of the COPD patients, and they are the signals of epithelial integrity. And again, they are uniquely associated with lung function, with positive and linear relationship between serum level and the FEV1 FVC ratio in former smokers with COPD. And unfortunately, hypermethylation and loss of the gene expression is seen in the airway cells of healthy smokers. So this can act as a prediction. This can help you to screen out those who are apparently healthy smokers. If they are having hypermethylation of this gene, that can predict future progression to COPD. The fifth one is the surfactant protein D, or the SPD. This again is a glycoprotein, pretty large in size, and produced in the lung by the type 2 alveolar cells. And the non-ciliated Clara cells also, they produce this. And what is its essential role? This is a more specific marker than CRP or fibrinogen for the differential diagnosis. And particularly, the levels are elevated in acute exacerbations, and a paradoxical drop is seen, unfortunately, in the BAL fluid in smoker segment. But it negatively correlates with the FEV1 and deteriorating lung function. And a clear cutoff level was identified in the ECLIPSE study with respect to the SCOPD and the AECOPD. What is SCOPD? That is the stable form of the COPD. And AECOPD is the acute exacerbation of COPD. So this is very important, because if you have a clear-cut level, you can distinguish the stable from the acutely exacerbating disease. And this is very, very important for pulmonologists, because that totally changes the direction in which they are planning the therapeutic protocol. So blood is not the only option. It's a very long, long road, and a tedious one at that. So we come to the even more non-invasive option, that are the urinary biomarkers. So what is the utility? Because they're absolutely non-invasive and continuous monitoring. You want to do an angiogram, patient says, no, acha, mera blood hi le lo. You want to do a blood test, and if they say, ek aur option hai, hum urine bhi le sakte, then the patients will all line up with the urine pot and say, fir urine hi le lo, because it is absolutely non-invasive. So another advantage is that, at least in case of COPD, the changes in the proteome are actually reflected earlier than in blood. And the changes can be detected well before disease evidence. So it can act as a very useful, very easy, very inexpensive screening tool, actually. So what are the urinary markers of interest? There are lots, among which we have fibrinogen, the CC16, CRP, as well as the TIMP, which is the tissue inhibitor of metalloproteinase, and of course, the quite popular now, NGAL, the neutrophil gelatinase associated lipocalin, coming from the neutrophils. They show significant increase in acutely exacerbating COPD from the stable state. So again, these are cutoff biomarkers. Another very interesting biomarker is the urinary desmosine and isodesmosine, because these are the molecules which cross-link the lung propoelastin to mature elastin. And when they are not used in the cross-linking, large volumes are excreted in the urine, which indicate very poor lung function because of lack of elastification of lung tissue. Moreover, urinary levels of platelet activation marker like the 11-dehydrothromboxane B2 along with the plasma soluble CD40 ligand and the soluble P-selectin, these are the very upcoming new kids in the block which are associated with worse respiratory symptoms, declining health status and very poor quality of life. And if you can detect all of these in by a simple urine test, even before the disease has itself exacerbated or when it is still potentially reversible, then you can totally change the outcome of this very bleak and very morbid kind of a disease. Now coming to the sputum-based biomarkers, what are the salient points in its favor? Induced sputum is again a non-invasive tool useful for particularly for lung neutrophil counts. And it is important for assessing the likelihood of damage from neutrophil release cytokine, chemokines, and proteases right at the very level of the ground zero. And induced sputum biomarkers are relevant for airway inflammation in asthma, not only in asthma, in COPD, you have, in asthma, it's IL-13. In COPD, you have the myeloperoxidase, the NGAL, both coming from the neutrophils. Or in both cases of asthma and COPD, this one, chitinase-like protein or the YKL-40. YKL-40, mind you, I personally worked with it in ovarian cancer. This is non-specific and it rises particularly in the inflammation setting of cancers. Here, again, this is related to inflammation of COPD. So it is basically a tripeptide and its name, as it suggests, comes from tyrosine, lysine, leucine, and it is a 40 kD protein. That's why it's called YKL-40. These are the promising candidates. And it reflects both the airway inflammation and tissue remodeling and can differentiate between asthma, COPD, and ACOS. This is the ACOS is the asthma COPD overlap syndrome, which actually makes the condition even more complicated. Some patients have this picture also. So sputum-based biomarkers are useful in this regard. The last segment are the exhale breath condensate-based biomarkers or the EBC. Now, what are the advocacy behind its use? The volatile organic compounds or the VOCs, which are exhaled in air, they can act as non-invasive biomarkers in the diagnosis and phenotype of lung diseases like COPD. Even the patient does not have to induce sputum here. Whatever is coming out in the patient's natural breath, that only is analyzed. So various analytes, they are measurable by GCMS. This is more specific, delineates individual markers, but it is more time consuming and expensive. Or the other alternative is an electrosensor, which is very popularly known as eNose, and that is non-invasive. But the disadvantage is that it recognizes patterns. It's like an array-based technology, but doesn't give very specific or pinpointed information in for individual biomarkers. So, but you can get a differential metabolomic profile on stable versus acute exacerbations, again, through simple analysis of the exhale breath condensate. And again, I'm saying it's very important to the pulmonologist to be able to distinguish between stable COPD and acutely exacerbating COPD, as everything from life expectancy to therapeutic outcome, everything changes. So they show promise as markers of early diagnosis, predicting prognosis, and tailor-made therapeutics. And this is made possible by simple assays, example, pH measurement, which is, and again, reduced in COPD in the ex-smokers, not in the active smokers. So what are the advantages of EBC use? Number one, it is non-invasive, it is inexpensive, not GCMS, but the eNose. Easy to collect, easy to repeat, not associated with any concomitant airway inflammation. It's very easily portable, suitable for all age groups from very small children to the very aged. And of course, this is a big advantage, can be performed even in mechanically ventilated patients who obviously cannot expectorate sputum out. So this is an advantage. And what are the biomarkers that you can assay? A huge number. You can do everything from reactive nitrogen species like nitric oxide, peroxynitrite, eicosanoids, cytokines, VOCs like the alkanes and the benzene derivatives, antioxidants like superoxide dismutase, ferritin, bilirubin, ascorbate, everything. Miscellaneous, including pH, carbon monoxide, viruses, DNA mutations, and reactive oxygen species also. So it's a huge and almost like a mall or a kind of a departmental store for biomarkers, if you can say. So in conclusion, sorry, the COPD is a heterogeneous and complex chronic lung disease. Identification of clinically applicable biomarkers are much required tool in disease management, and the ECLIPSE study has thrown up such a huge number of candidates. They can act as a definite help in disease diagnosis, monitoring, progression, and exacerbation, as well as influencing therapeutic strategies and prognostication. What is important is to overcome the methodological challenges in sampling and quality control, and that will enable an even more robust and more easily accessible biomarkers to be developed, and that will actually help in improving the therapeutic outcome in patients with COPD. These are some of my references which I've used. Thank you.
Thank you. This is an excellent presentation. And I would like to open it to the forum for any questions.
Any questions, please? I think there are no questions.
There are no questions. So either it was very good or it was very bad. Those are the only two possibilities. But thank you.
I have one question.
Yeah, sure.
Other than age range, the CC16 also have got some immunity for the smokers.
Not particularly. So don't be too hopeful. S-rage definitely has. CC16 has been found to be negatively correlated, but as such, it is the S-rage which has offers a kind of a natural immunity to our smoker population for reasons best known to God. What can be the actual rationale is that smoking, it stimulates a subclinical and indolent level of inflammation throughout the life of the smoker. And that is why, as a compensatory upregulation, the soluble fragment kind of increases its level. And to some extent, it offers protection. Why? Because, as I said, it acts as a decoy receptor. So it goes and binds all those harmful molecules which are actually the advanced glycation end products or similar pro-inflammatory molecules, and prevents them from binding to the membrane-bound receptor and stimulating the inflammatory cascade, which in turn leads to the lung damage in COPD.
That is S-rage. I'm talking about Claracell.
Claracell protein, Claracell protein, those are not so much, they have not been that way identified as being protective to smokers in any way. They are negatively correlated, and they have been found that higher levels are protective against COPD. But whether they are protective in healthy smokers, that is again a subject of discussion. Because mind you, cigarette smoke actually impedes the action of cilia on the ciliated cells. And Clara cells, by their own morphology, are non-ciliated cells. So they are a different population. But yes, they do reflect epithelial integrity, and that epithelial integrity is very much compromised due to long-term smoking.
Thank you.
Yeah, not so lucky for smokers. One is good enough. Thank you.
Thank you so much, madam. May I request Dr. Susruta to please felicitate our speaker?
Sorry for my hand.
But although it is like you are hurt, you have come. So we thank you for that. Thank you so much. So may I? Yeah. May I request Dr. Thuppil to, Dr. Susruta, can you stay on stage, please? Your chairperson, Momentum. May I request Dr. Venkatesh Thuppil to please felicitate our chairperson? Thank you. Thank you so much. May I request Dr. Deepti Jain, our next speaker, to please come on stage? And may I request Dr. Asma Bibi to chair the session, please?
Good morning, everyone. So I'm privileged to introduce Dr. Deepti Jain, who is the lab director at Miyot Hospital, Chennai. She'll be talking on workflow and process improvement in clinical laboratory through automation and digitalization. Dr. Deepti is a MD Path, and she is having a 14 years experience in lab medicine and pathology with areas of specialization in oncopath as well as transplant immunology.
Thank you, Asma.
Over to you.
Good morning, everyone. First, I would like to thank the organizing team of Mindray to having me here and giving me the opportunity to share my experience on this topic, which is the process improvement through automation and digitalization. For the next 20 minutes, I'll be taking away from the core biochemistry, which we are discussing from the morning, and I'll be taking you through the process improvement in overall lab, but mainly I'm emphasizing on the clinical core lab. So this is Miyot International Hospital, a 1,000-bedded hospital, tertiary care center, which is situated in the center of the Chennai. We deal with 60 different specialties, and we have all the services in the laboratory except histopathology and the molecular diagnostic. We are serving 24/7 to our patients, and we receive around 1,000 to 1,500 samples per day for the processing. So why this topic? Why I'm talking of digitalization right now? So yesterday I just went for a short walk and I went to one souvenir shop, which is a small souvenir shop. And because I wanted to take back something for home, and I asked, I just forget to carry the cash, and I asked, do you have GPay? He's like, हाँ मैडम बिना GPay के काम कैसे चलेगा? Means I cannot work without GPay. I cannot improve my business. Same way, the why not lab? Why not the lab which is dealing with the most important part of any hospital, because we are the backbone of any services. So why not we adopt the more and more automation and digitalization for the improvement of the laboratory services? So the main aim to understand the importance of automation and having an integrated laboratory structure to support systematic improvement and sustainability. We all know the role of laboratory medicine is changing. Earlier, we used to talk, we will be more specimen centered, we will be more believed on the clinical testing, only the lab performance, and we believe we are just the provider of results. But not now. We are not just the specimen center. We are more worried for the patient outcome. We are equally important for the clinical decision making, because as we know that even the guideline says, we are the advisory services. Anything, any results, if we give abnormal, the first call comes from the clinicians. Deepti, what to do next? Which test you require the next? If I'm giving any variant in HbA1c, what you want to do me the next? So we are not just stop with the providing of results. We are the advisory services. We believe with the patient outcomes, not with just the results. And we are the partner in care. So for me, the diagnosis is effective only if it is done at the right time and if it is reaches to the clinician or the care provider at the right time. Then only diagnosis we can tell, yes, it is an effective diagnosis. So I'm sure each one of you all facing the laboratory challenges, whether it is a hospital lab-based lab or it is a standalone alone laboratory, especially during the time of COVID when the volume increases. But we have the same space optimization. We have to be more vigilant for the quality because we have to follow all the guidelines for the quality assurance. We have to reduce the waste. We have to reduce the storage reduction. At the same time, we have to maintain the turnaround time. And I'm sure you might be agree that whatever good the turnaround time we give to our clinicians, they always expect much more. If we are giving my results in 4 hours, they want within 3 hours. They want immediately when the sample is taken out from the patient. And we have to do the peak management also. Along with this, it is the training, which is the very important part and which is very crucial. It is the staff training. Because the more we introducing the test, the more, but the staff we need to train, and it is not in the particular subject. We have to give the cross training so that we have the peak management. So what is the benefits of automation? So here I can take the general term automation. It can be automation from the semi-automated to fully automatic analyzers to more integrated automatic analyzers like we have in Mindray, or we can talk about the total lab automation. So automation, basically, it increases the efficiency by accelerating the workflow. And yes, with the advancement of technology, it increases the precision and accuracy. We have more data integrated. We can have the whole lab data integrated at one place. It is definitely help us to reduce the turnaround time. And yes, the improved quality and safety. But any automation, any type of automation, it comes with challenges, whether it is the higher initial cost, higher risk of downtime. I'm not sure how much of you are tech expert, but for me, takes time to understand the computer, to understand the software. So when it comes to the downtime, yes, with the automation, there are chances of downtime. Here comes the role of training. Here comes the role of SOP, how we make the SOP in the lab to maintain that downtime. Another thing is the psychological dependence of the laboratory technologist. And yes, where he have the redefinition of the job roles for the laboratory workforce. Whenever we are introducing the automation in the lab, it is not the doctors which we have to train the laboratory technologist, we have to redefine the role, and I can tell you it is really a Herculean task. So if I'm talking of total lab automation, so that is not only for the analytical, it involves the pre-analytical and the post-analytical phase. And yesterday, I'm sure you all have heard Dr. Manisha's talk, which was excellent on the post-analytic automation and which made my work very easy, that is auto-verification. So I'll just deal with in short with all the areas. So talking of laboratory workflow, so if I'm seeing in the laboratory, it is not only the samples which is coming. So we are not only concerned with the sample collection, sample accession, how much time we are taking in decapping, recapping, storage, but there is lots of data also which is flowing in the lab. So like the quality control, equipment monitoring, result review, validation, etc. Along with data, we have a material flow, if I'm talking in the lab, which means the inventory tracking, inventory recording, utilization of reporting, cost per result management, billing, etc. So we cannot concentrate only on the samples. We have to see the data, we have to see the inventory, everything in the lab. So this is just a workflow layout I just wanted to show. This is the physical layout and the workstation, which is our lab, which is like an effective way. We have a connected hematology and the clinical biochemistry and clinical pathology area so that there is more interaction and we can have a more integrated approach to the results. Now I'll just take you quickly to our process excellence assessment, which we have done pre-automation and the post-automation. So this is, we call it as OPD process mapping. So when we do the process mapping, we cannot just do when the sample is coming and when the report is releasing. We have to do the process mapping from the starting, from the time the patient is arrived, from the time we have given the TRF, then how much time the patient is waited, then when the barcode generated. Like that, we have done the process mapping for the single sample, like for many samples, till the end when we are authorizing the report. And the whole why we have done the whole exercise to find out where are the bottlenecks in our process, so we can go and work on that improvement. This is before applying the automation in the lab. So we found out where many bottlenecks are there. The most important bottleneck is the multiple manual entries, which we do at multiple levels, and we do not realize what all we are doing in the manually. Another very important thing, which I'm sure each one of in the lab, the technicians moves around among the machines to go to the samples, to give the samples the movement and the storage of the samples. When we go, we want to repeat the samples. The samples are stored at one place. To go and find out the sample particularly, it takes time. So what we do initially, we have to call back the patient, call them and do the repeat testing. So we need the fresh sample. That this is for the pre-automation area time. So then we have introduced in 2007 the automation. So this can be done at any level per the lab requirement. Whether you can go only the analyzer automation, or if you have a big workload, you can go for the pre-analytical automations, or if not pre-analytical is required, you can go for the analytical automation. It totally depends upon the lab, what is your requirement. But for that, you should know your process mapping of the lab, how you can improve your lab process improvement. So what is the benefits? Yes, we have got the optimized turnaround time. We eliminated the need to move the sample trays and need to allocate samples. There was more harmonization and efficiency, optimizing the sampling order to balance the processing demands across technological modules. We can run the multiple analyzers parallelly and get the integrated data. So this is just few quality indicators which I have mentioned, we have compared the pre-automation and the post-automation area time. So if you see the error in labeling, before automation, we have sigma of 3.5, but when we started the barcoding and automated sample sorter, it has changed to 5.7 sigma. Similarly, rejection rework. We have more rejections because everything was done manually. So it was the 3.8 sigma. But when the advancement of the analyzers comes, where you can have the HIT indices, which like in all advanced auto analyzers we have, the rejection rework sigma has increased to 5.1. There's a significantly increase in the Six Sigma. Now coming to the analytical phase. So here, if I see some of my quality indicators, initially we have to load the manual loading of samples individually, where the result recall, because the IQC is very important, but the IQC bracketing, when we do the manually, we do not have the integrated approach. That takes some time. So result recalls because of IQC failure was only 3.9 sigma. But once we have done the IQC bracketing in the analyzer itself, in the middleware itself, our sigma has increased to 5.2. Amended reports, most of the time, and the reports were getting amended because of the error, technical error or typing error. It has increased from 4.3 sigma to more than 5 sigma. But was this enough? That we can just stop with that? No. Because as Madam was discussed yesterday, we have a big bottleneck at the post-analytical area, where we are doing the manual result verification. And that is the biggest bottleneck in any lab which is dealing with more number of samples. Because you have to see the normal result, you have to see the abnormal results, you have to sit and see the delta check, you have to do the critical alert, you have to inform the critical alert on time. So that is the one biggest bottleneck which we face in each lab. So here comes the role of instrument manager. So what is instrument manager? It is a middleware, a software which acts as a connection between the operating system and the applications. So basically, we can manage with many things with the instrument manager. You can connect multiple disciplines, you can connect multiple LIS, you can connect multiple sites. Your productivity will get streamlined. So you can have auto verification, you have intelligent sample routing, you can track your specimen, where my specimen at present. You can consolidate the quality management information, so which we are doing the patient safety at the largest. You have an integrated quality control. You can combine the proficiency testing reporting in that, moving averages, etc. Then management. Yes, all the labs have a huge data. So with the middleware, with the instrument manager, we can have a data collection and we can have a laboratory analytics. Now coming to the post-analytic phase, again, this is the analyzers, automation. It is going to the server of the middleware. Middleware is connected to the LIS. And then it is going our electronic medical reports and that. And this is all will be taken care with a good IT team, which is having a good security backup system. So this is just few examples I will give you where my instrument manager or the middleware is helping us. So I cannot go in detail because of the short of time. I'll just show you some few examples. So this is one of the thing is order list with pending. So when we have to go and check back our pending list, I'm sure when we have a huge number, it takes a lots of time. If we are only depending on LIA, sometimes we just miss. It is in the collected state, it is in the ordered stage. We miss the patient samples pending. But if we add the middleware in that, you can just in one screen, you can have what are all the pending samples are lying down, which stage your sample is pending, whether the sample has reached to the lab, whether it has been collected. We can have a consolidated list, and definitely we can improve the turnaround time for those samples. This is another very important area where we can do the live tracking of our sample. Sometimes we know our sample is pending, but where is my sample? There is like become like, where is the sample? Where is the sample? But if it is in the track thing, we can know at particular time where is the sample. We can track the sample in that system. Then comes the auto verification, which madam has taken already in very much detail. And I can tell you right now, we are doing the auto verification only in the clinical chemistry. So our auto verification rate is around 70%. Hematology, we have not started the auto verification because of the limitations as we have discussed yesterday. But clinical chemistry, yes, we are doing the auto verification. So these are some of the things which we are putting in our middleware. We have given multiple colors in the middleware where you can see when the start test is coming, whether it is cancelled, whether it is auto-verified. Whenever the critical test is coming, it will show the red color. And if we are doing a critical alert manually, I'm not sure how the process in each lab, but when we were doing initially manually, the technologist has to write down that what time he has reported to the clinician, and everything is manual. Means the traceability just depends on the honesty of the person who is reporting. But when we bring it into the middleware, when we bring it in the automation, our result will not be released unless he will not enter which he has informed. Once he will enter in the system to which person he has informed, then only our result will be released. So they cannot goof up at that area. They have to enter the correct information, and we can capture the correct time, exactly what time the critical alert has been given. Then the next thing is delta check. Again, when the result held, it comes with a different color. We know why my result is being held. And all this color coding we have defined internally, as ma'am has told that we have to define the algorithms. We have defined it, and we have given in different colors. Other than that, we can show the equipment maintenance. So there is another thing which we can do in that is this is just an example of the held for verification. So if you see, our results are held for verification because it is out of the reference range. So like that, the color will come. And here we can see, we can enter the reason for held for verifications. Once you go back, you can see why my result is held for verification, whether it is delta check or something else. So we can enter the reason. So at the end of the day, when you can have a data of your results, why it is held, you know the reasons why exactly my particular number of samples has been held for verification. So the post-analytical phase, if I see some quality indicators, so again, I told the amended reports, the sigma is drastically improved. Delta check, which manually will take much more time. We are able to do all the delta check within 10 minutes of many number of samples. Critical alert intimation, again, I told this is the area where we have seen a drastic improvement. Within 10 minutes, we are able to lively inform the patient of the particular clinician, whichever that sample belonged to, and we are able to track it at the live. We have the live record of our critical information. So this is just the graph before the pre-automation and post-automation. Earlier, the turnaround time was 3.9 sir average. Now our turnaround time decreased to 1.8 hours. As I told you earlier, we have get the reasons why the delta check is being held, and we found out that the most common reasons are the sample issue, the specimen collection issue. So with the data which we are getting from this graphs or from this evaluation, we can use for the training purposes. We go back and train our technicians, our phlebotomists, our nursing staff. What is the reason for the health for verification? Another thing, as I told, our IQC is being integrated into the system, into the middleware. We have more IQC failure recalls after implementation of total lab automations, because earlier there was some missing cases where we are able not to find out the IQC failure, but after implementation of total lab automation, we have more IQC failure recalls. And yes, as I told, all the technology with the advanced technology, HIT indices, your rejection work will reduce drastically. Once you involve the technology in your lab analyzers, your rejection work will decreases. So similarly, our rejections due to hemolysis rejection work repeats have decreased tremendously. So what appropriate integration will do? For the healthcare institutes, it can save money by reducing the operating cost. It improve the reputation by increasing performance and quality. It increase revenue and increased volume. For laboratory, yes, it provide the higher quality of results. It delivers faster results so that it can give the clinician satisfaction, more consistent results with less errors. For technologists, how this automation can help to technologists. It reduces the laborious task where it is not required their skilled work. They will be have more job satisfaction. They have more free time to focus on the skilled work rather than wasting the time on the unskilled work. So if we remove the unnecessary register work, entry work, collecting data work, we can utilize them in more effective way, and we can give more training, we can give more cross training, and it will help us to manage the peak management time. And any good work, it is not possible without a good team. And I would like to thank my team for having me, because to do the automation, it is not an easy task to maintain the computer, to middleware. And I really like to thank the team, the dedicated team of Miyot Hospital. Thank you so much.
Thank you, Dr. Deepti. The house is open for any questions to Dr. Deepti.
Any questions?
Ma'am, which middleware you are using and what is the recurrent cost that comes for them?
So this is actually the cost we have employed long back in 2018. So we are right now using Instrument Manager.
Of the instrument itself, or
No, it is a third party. It's a third party which can be applicable to any instrument. You can connect the different type, any different company instrument. So it's a third party instrument. Though actually now it can comes with the, if we are going for the total lab automation, we can have a discussion with the vendors also who is providing the total lab automation. That so the cost bearing will not be come on the only on the hospital. So,
what will be the annual maintenance cost for this software?
that this will be more, it is not very high because it has been taken care by our lab person who is giving
IT
that.
person.
Yes,
Okay.
IT person and the total lab automation department.
Okay.
So it is not coming directly to the lab. So it depends upon the requirement of the lab, what any lab can handle. Depending on the requirement, we can go for the middleware or the part of automations.
It's not definitely open source, no?
It is not, it is a third party, sir, but it is not like for that particular system. You can connect with the another system. So depending upon the workload also it comes, how much you have workload, whether it is beneficial to go for the middleware, but it like a open source. You can connect the different type of companies.
Yesterday when I presenting, I was thinking, no, can the whole laboratory community create something like for automation interface? Because these are all things that will reduce our workload as well as improve our efficiency.
Yes.
And these are the areas we are struggling.
Yes.
So if the community tech is coming together, can we make better, feasible? And when you have used it for long years, you know the experience and what are the struggles.
Yes,
how
sir.
can we make it improve and make it useful to others also?
Sure, sir, definitely. Actually, we used to take more workshops. We had plans for CME and we have done for some workshops for Instrument Manager only to make accessible to the people how we can utilize it, because when we use it, we have actually realized it is really useful. So we have to increase our, as a head or as a pathologist, as a biochemist, we have to look that because I think the doctors are the least experienced in the technology. We are always fearful of touching the computer and we are always prefer the manual work, but these things actually it worked out for us a lot. And we have great traceability of our errors. It is not like we are giving the results. Even we can trace our errors also accurately. Till the starting point, we can trace our errors.
I totally agree. Ignoring it's good to know what is there and where is the error instead of ignoring it and
exactly.
being sitting on top of it without recognizing.
I think there are no further questions. So thank you, Dr.
Thank you so much.
Deepti.
Thank you, Shama.
And thank you, Dr. Asma. May I request Dr. Asma Bibi to felicitate our speaker, please. May I request Dr. Riju Matthew to please felicitate the chairperson? Madam. Thank you, Dr. Asma. Thank you, Dr. Riju Matthew. May I request our next speaker for the day, Dr. Ilangovan, to please come on stage. And may I request Dr. Venkatesh Thuppil to chair the session, please.
Thank you for again and again keeping me awake. I don't know why you select some people whom I know very well. Yalangovan is a quality manager, Anderson Diagnostic Lab. I don't know for how long I know you. You remember?
Yes, more than 10
I
years.
know him even before his children were born. They call me grandfather. That is my relationship with him. Therefore, the topic equipment, part of technician life, and technician is part of our life. We are part of patient's life. And very good topic, very philosophical to think of when technicians are the backbone. Now, he is a PhD in biochemistry, having 15 plus years of rich clinical experience in the field of healthcare. More than that, he is capable of building laboratories. That is the beauty of that. He is not just a man behind the machine, he is a man behind building the laboratories. That's what I have seen. He is a very busy man, and he is also trained international lead assessor in Nepal. And he is also a very good teacher. He is one of our faculty at the Foundation for Quality India because of his clarity in understanding. And of course, the Foundation for Quality India for Tamil Nadu chapter, he is the secretary, come faculty. And he is very proficient in handling the latest laboratory equipment. Of course, with NABL and ISO, NABH standards, and he is a good friend. He is a good handholder, you know. A key team member of the top management in taking important clinical diagnostic decision. And you will know now how good he is in delivering the information. He's a good teacher, trainer, and he has, I'm sure, he's quite young. He has a lot of time to, paper publications, more and more in days to come. Over to you.
Okay.
Rango.
Thank you, doctor. It's our teacher. It's like a guru for us. Okay. Thanks for our wishes and to introduction to me to the forum. First, I would like to thank my organization, Anderson Diagnostics Labs, and the Mindray team to given the wonderful opportunity to give the lecture on that equipment automated analysis at the part of the technician life. Actually, as you know, the total laboratory process is start with the patient goes to the doctor. After that, our community is working on that and delivered that examination result. As you doctor said, this examination results, it's having that valuable information on the clinical information about that patient. Again, goes to the doctor. It's when the total process complete the cycle. And then this total process, laboratory process, is supported by the IVD medical devices. The IVD medical devices is having the various phases in pre-examination, examination, post-examinations. So in the form of collection device and the up to the post-analytical part, the storage device also. And then here, the auto analyzer is playing the major role in the IVD medical divisions. So what is that auto analyzer? Is a medical laboratory instrument designed to measure the various substance and other characteristics in the number of biological sample quickly with minimal human assistance. This is a very, very important why we are choosing that auto analyzers. And then auto analyzers uses and advantages is reducing the human error. We can reduce the human error and then ensure the safety and decrease the laboratory cost and improve the turnaround time and increase the productivity, run more tests at a time and operate with the fewer instrument and they ensure the accuracy and they ensure the repeatability and reliability of the test results and then the integrated data management system and both patient sample quality control data and then calibration data. If not auto analyzers, we have to written in that manual and maintain the data. But if you are using that auto analyzer, you can store the all the data in there itself. Yeah, as you know, human being also having the some life cycle. Fetal form, the newborn fetal form in the womb up to the old age. Same like that, auto analyzers also having that some life cycle. If auto analyzers is like a newborn baby in the manufacturer site, there itself design and development is there. After that, it's born in laboratory. So when the birth, we are getting the birth certificate like that for the equipment. So installation report. After that schooling, we are performing the evaluation, precision, accuracy, and validation, and linearity. All those things we have done. After that, adult and work age group like that, we are doing that, running the test like the IQC, EQA, or patient samples. In between, we are doing the some marriage formalities also for the equipment, like the interfacing. And then old ages, this is a retirement age. This is the life cycle of that automated analyzers. And then we can divide it into two portions. One is a manufacturer site, another one is a laboratory site. In laboratory user site, what are the things we need to check? Once with it is started with our auto analyzer life cycle from acquisition and procurement. When the procurement of the equipment, we need to following the three steps. One is need to assessment. What are the things we need to assess? What is your requirement? What are the type of test we need to do? And then cost and efficient, everything we need to check. And compatibility of the existing equipment. And then same like that, in the selection, you are check with the reliability, accuracy, and performance of the equipment. After that, purchase and installation is started. After that, once the purchase is completed, the machine is delivered to the laboratory. The installation, initial testing and calibration will be taken by the supplier or manufacturer. And then training is given to the users, end users, by the application specialist of the company. And then after that, the technician, after getting the training, a technician started to operating utilization of the equipment. Routinely, we are run the samples and every day do the some maintenance like cleaning, and then some other daily maintenance or routine maintenance we'll do as per the manufacturer recommendation, and performance monitoring throughout the performance life cycle of the equipment, operational life cycle of the equipment. You have to validate the performance monitoring. And then preventive maintenance and corrective maintenance. The preventive maintenance is a scheduled process, a pre-planned process. They are cleaning the equipment by the engineer, and some of the doing the some alignments, some lubrications will be there, some spare will be changed, some kind of activities will be take care of it. In the corrective maintenance, the technician can do the alignment whenever the machine is breakdown. And then other part, if it are not at all solved by the end users, they call the engineer will come and do the some corrections. This is a service maintenance. And then sometime the equipments need some upgradation in the software side or firmware side or hardware upgradation, we do it. And decommissioning, the end of the use of the life cycle, and replace the thing. Why we are decided to end of useful life of the equipment? So decreasing the efficiency, the alternative approach will be there, the updated technology is there, so that we have decommissioning. So after decommissioning, the dispose or recycling the take place of that equipment, like the people, human being. So in the entire life cycle, the risk is associated. How the our life cycle also having the associated with the risk. Same like that, auto analyzers also having the sum of the risk from it is started from the manufacturer end also. What are the factors involving that risk associated in the auto analyzers in manufacturing? And poorly defined product development process. So poor understanding of the user's need. Sometimes they are manufacturing their own way, but not understanding that user needs. And then too little time spent on design inputs, and then started the risk management too late. And then poor design review, design verification misses to mark, and then design verification validation is inefficient. Poor design changes practice. how to rectify. So always wherever you are searching, some of the guidance is there. Same like that, as the manufacturing also having that guidance, CE certified or FDA approved for the design and control, and then same ISO certified for 13485 medical devices. And then another part there itself they can correct it. So how to review it? First, we are planning to the understanding the user needs, and after that they should design the input. After the design process, after design output, again they have to validate. If you need any correction, they need take the corrective actions for that corrections, and then again plan for the design input, and again same process continue. The medical device is manufactured, and for the validation, the validation takes place in the manufacturing part. After that, it hand over to the end users. This is a cycle they have followed now. We can reduce that risk. Same like that, in laboratory also we have that risk. So what are the things we have? Selection, installation, calibration, validation, maintenance, troubleshooting, service and repair, users, and retired equipment disposal. In selection, what are the things? Inappropriate size of the design. So mostly we have selected that equipment before seeing that equipment. So once they delivered, we are searching the place to install. So it's not accompanying the equipment in the inside the laboratory. The size may be the big, and then outdated technology. So we are procuring the equipment, but it's not fit for us. It may be the outdated techniques, and then outdated methodology is there. So sometimes the equipment is given the poor performance like inaccuracy and imprecision, and then equipment downtime will be the more, and the not fit for the user's need. We are expecting for the analyzers for the random access, it may be the batch analyzers. So it's not fit for our use. While the installation, the engineer has to fail to pre-installation site visit, and then inappropriate space for the equipment. So all the labs we are given the space for the equipment. We are arranging the equipment like a godown. So near to the wall, we are try to fixing that all the analyzers. So it may get the chances to malfunctioning of the equipment, and then risk also, and then bad environmental. So we are we are having the challenges to maintain the lab in the very clean manner. The dust accumulation is more. So if we are not properly cleaning the bad environmental, it's always there. It also risk for the equipment, and then uncontrolled temperature. So we are always checking with that AC. We are one minimum requirement of that installations. We are fixing the AC. How many people are checking that this is sufficient for that air condition for that particular room? So no one calculating. So we need to get the some consultant for the AC consultant. We are calculating the heat load with the how many people are on the shift, what are the equipment we have to install, what is the size of the room, where it is present at the room in the top floor or middle of the building. So we have to calculate the heat load, and after that we have to design that AC control, how much time we have to install, and that improper power supply. The power supply is a major role in that operating the auto analyzers. It's not only for hematology analyzer, it's all the analyzer it will affect. The earthing should be the proper, and then 230 volt, and the online UPS should be must. So same like that, we need to provide the all proper power supplies. And poor water quality. So mostly we are using that deionized water for auto analyzers, but we need to monitoring the water quality, how the deionized water we are getting the properly or not. We need to monitoring the conductivity and the TDS also. We can, after that only we can ensure that quality of the performance of the equipment. Otherwise we are fail on that. Same like that calibration. The calibration considers a two part. One is the analyzer calibration. Another one is a analyte calibration. In analyzer calibration, undefined timely calibration. The manufacturer given that time interval for the while the validation, and same like that we can also fix for that time interval for the verification. While the verifications also we need to stick on that. If you are failing on that calibration, the machine will given the wrong results. And then unfocused calibration lot. Mostly the calibration lot has been changed in the analyte calibrations. People are not aware of the changing of the calibrator. They are using the same calibrator. It may be given the some calibration error or shift may be the occur. We are getting the poor results. And then invalid calibration. Sometimes the error may be occur, but they are not notifying the thing. So invalid calibrations is occur. The calibration document is missing. Always the documentation is very, very important to take the corrective action to do some data analysis. So when the shift is occur, when is trend is occurring, so we need some data. So we should properly maintain the calibration documentations also. And then in maintenance, disobedient of the manufacturing guidance. Manufacturer clearly mentioned that when we need to maintain by the technician, when we need to maintain by the service people, what is the frequency of the preventive maintenance, what is the AMC, they are clearly maintained annual, bi-weekly, bi-monthly. So they are clearly mentioned, but we are not always obeying manufacturer thing. So we are skip on the thing. Same like that, invalid maintenance, undefined timely maintenance, try to reuse the spares. Sometimes electrodes in biochemistry analyzer, electrodes, cuvettes, and lamps, and all the peoples are trying to reuse it and save the money. The time that maintenance fault may be occur, and then skip the PM. So always we are focusing on the TAT and running the samples. We are not allowing the machine to the engineer to do the proper preventive maintenance. The time we are getting that fail. Same like that, maintenance document is also missing. So everyone should maintain the equipment history record to what are the service we have to do, what are the preventive maintenance we have taken care of the thing. So we need to maintain for the equipment record. Same like that, troubleshooting and service and repair. The transparency missing from that user malfunctioning or manipulating that some of the equipment, they are hiding the things. So this hiding is not helping to the service people to take the corrective action based on the root cause. So users should always the transparency what they have done it in by the mistake. So after that only the service person can do proper services. So invalid error data documented, and then same like that, ignoring the error. The all equipment having made up of the sensor, not only sensor, it's a good sense also. It's always sense the error and give the erratic informations, but people are not notifying that alarm. So ignoring the just like that, and delayed the information from the laboratory. Once the alarm has come for the some major informations for minor things, but they are peoples are delayed to the informing from the lab to the service person. So it will in the meantime we are affecting the more. So skipping the changes in the spare. So periodically we need to change the sum of the spare. That time we are skipping the thing. Issue fixed with the temporary solution. Sometime not the spare is not available. We are sometime do the some temporary solution. It may be the harmful for the analyzer. And then user side, the lack of training by the laboratory technologist. The technologist not understanding about the equipment performance, equipment linearity, and limitation of the science that leads to issues. And then lack of technician training in the biomedical engineers. Sometimes the biomedical engineer from company side, from the lab side also, is properly not at all trained. They are getting the problem. Same like that, retirement of the equipment. So try to retain the older equipment. So always it will happen in the lab for undefined retired stages of the equipment, spare unavailability, and then unlabeling as a retired equipment, refuse to adapt the new things. So that we are keep on that old equipment, improper disposal of the equipment. These are all the risk for the auto analyzer in lab side. What is the solution? The only solutions we are getting the accreditation based on the ISO 15189-2022 or 15190-2020 for medical laboratory requirement for the safety, and then training for the lab staffs for the equipment maintenance. So have you seen that every people's having that own equipment? They are treating that equipment as a god or the family member, taking care of the love with the love. Like the musician equipment, tailoring, carpenter, artist, civil, same like that. Equipments are in that part of the professional peoples. Same like that, our technician also take care of our equipment as a part of the life. So take home message, equipments are obedient servant to us. If provide the clear, well through out command, you will achieve the good results. However, you are foolish. Thank you.
Thank you, Dr. Elangovan. If anybody wants to make any comments, provide inputs, or get clarification, most welcome.
Yes, Dr. Elangovan, for your
And
informative lecture. What are the indications for which we have to discard or discontinue an auto analyzer, apart from the time frame given by the manufacturer or its performance? Is there are any indications that we should go for a new one?
Not like that. Every day you are running the quality control. Whenever the quality control is failed, the performance is decreased. This is the only indication. And sometimes the spare is not available. So software updation is not available. It's not adapted for our new things. So that time we can replace it. If it is working fine, it's going well. It's not a problem for that manufacturer time frame. Based upon the performance only, you can decide.
Thank you. Just to add on to this, I'm from an academic side. We have started a concept called Biochemistry Museum, in which what we have done in our department, we are not condemning our instruments. In spite of that, we have started a museum, or it is a instrument library, in which I have displayed, starting from a simple photometric calorimeter to a auto analyzer, how the biochemistry has transformed. To which a DMLT students, BSc MLT student, MBBS student, MD and PhD scholars, and we have opened the instrument. They can come and see, visit, learn. So starting from a simple calorimeter, then spectrophotometer, UV double beam, single beam, semi-auto analyzer, to a auto analyzer we have displayed. So,
Yes, it's a good initiative.
that is what we have done.
In our career things, Dr. Tupil Venkatesh sir and all, while they started the career, they are manufacturing the equipment and formulating equipment and to do the thing, what color is performed the end of the reaction, they know very well. The root cause also they know very well. But our end, we are directly using to the colorimetry and automated. Fortunately, we are having that option. Other people sir doesn't have that option to the what are the basic things. So this is a very useful to the another next generation to learn the basics. Thank you.
Anybody else?
So no further questions.
Thank you.
So may I request Dr. Thuppil, we'll just bring it over here. We can, every time he has to climb up. But mentally, yeah. Thank you so much. Thank you so much, Dr. Venkatesh Thuppil. Thank you, Dr. Elangovan. Yeah, I will write. So, the young Dr. Thuppil, I would like to present you with a great thank you. And may I call on stage Dr. Mudita Bhargava as our next speaker. And may I request Dr. Vinayaga Murthy to chair the session, please.
So very good afternoon to everyone. I'm very much privileged to introduce Dr. Mudita Bhargava, who is a consultant in clinical laboratory. She has 4 years of experience in clinical laboratory medicine, and she has a lot of experience in NABL as well as NABH. And Madam will be talking on HbA1c and other advanced markers for diabetes monitoring. Welcome, ma'am, and over to you.
Thank you, sir. Good afternoon, everyone. First of all, I would like to thank Mindray for giving me this opportunity to be here. I've been attending the session since yesterday, and they're all my teachers and seniors giving lectures. I'm probably the most junior person here, so thank you for giving me this opportunity. Starting with the session, my topic is HbA1c and other markers for diabetes monitoring. I will basically be focusing on HbA1c. So, what is HbA1c? The definition is HbA1c is a form of hemoglobin that is chemically linked to glucose. It reflects the overall glucose levels in the blood over a period of around 120 days, which is the lifespan of an RBC, 2 to 3 months. Glucose, when it enters the bloodstream, it attaches to the hemoglobin in red cells, and higher is the amount of glucose in the blood, there will be an increased amount of HbA1c. Why is HbA1c is important? Because first of all, it provides an insight into a long-term blood sugar levels around 2 to 3 months, 120 days. It can be done at any time of the day. We don't require fasting requirement as for fasting blood sugar. And then it is also not affected by diet, exercise, or any other emotional disturbances on the test day. Clinical significance, it can be used in screening, it can be used as a diagnostic modality, it can be used as monitoring. Basically, it can monitor and manage and follow up treatment of diabetes. We can use that. And a very, very important use of HbA1c is that it predicts complications. Higher levels of HbA1c are associated with an increased risk of all diabetes-related complications such as neuropathy, retinopathy. The normal and diagnostic ranges. The standard protocol says that an HbA1c of 6.5% or higher on 2 separate occasions, it confirms the diagnosis of diabetes. Other than diabetes, other than like for using diagnostic purposes, HbA1c is very helpful for like screening of diabetes in the pre-diabetes patients. A range of 5.7 to 6.4 is the cutoff. Normal people have less than 5.6, less than 7, sorry, up to 5.6 is considered normal. Between 5.7 to 6.4 is the pre-diabetic stage, which is very useful because diabetes has not yet started. So if we screen patients in this category, we can, before giving medical treatment, we can modify the lifestyle, and basically we can avoid using drugs to monitor, to control diabetes. Frequency of testing is for well-controlled patients every 6 months is advised, and for those with poor control or changes in treatment, we do it every 3 months. People who already are diabetic, who have been diagnosed with diabetes, in these category of patients, an HbA1c of below 7% is considered to be the goal, the target. What are the factors affecting HbA1c? First is anemia and blood disorders. In all conditions of anemia, obviously, if you have anemia, there is a decreased red cell turnover, so it will indirectly affect the glucose HbA1c levels. Kidney disease, impaired kidney function can lead to an inaccurate HbA1c readings, and ethnicity. Certain populations naturally have a different HbA1c level due to genetic factors. Now, standardization of HbA1c is very important. We are saying HbA1c is a very important diagnostic and screening test. So we have to be very sure that every lab has a set standardized range or a standardized method, because if one lab gives a different result and another lab gives a different result, then the clinician will be confused what exactly is to be followed. So it is very important to have a standardized parameters for HbA1c. Now, standardization of HbA1c goes back to 1980s. 1980s was the first time when the American Diabetes Association and the National Institute of Health, NIH, they began advocating that maybe HbA1c should be used for monitoring and managing diabetes. But global standardization, it took time. From 1980 up till 2007, there was no global standardization. In 2007, IFCC They introduced HbA1c measurement and they introduced HPLC basically as the standardized tool for monitoring HbA1c. The current standards, it states that IFCC is the reference system for HbA1c and is the only valid anchor to implement standardization. So all the societies like American Diabetes Association and European Association for the Study of Diabetes, International Federation of Clinical Chemistry, they all agree that we will follow IFCC for the standardization of HbA1c. Now, the different methods of HbA1c, we can do it by HPLC, capillary electrophoresis. These two are based on the electric charge principle. The advantage of it is that they have the ability to distinguish between hemoglobin variants. The other methods, which are more commonly used in a low resourceful setup of lab, immunoassays, enzymatic, and affinity chromatography, these are based on the structure. So now starting with HPLC, HPLC separates and quantifies the various forms of hemoglobin, including HbA1c. It is highly accurate, reliable, and it is considered as a gold standard. The only limitation of it is that it requires specialized equipment. It requires trained pathologists to actually read the graphs and interpret the results and the variants, and it has a longer turnaround time. Immunoassays and enzymatic methods, they are quick, they are relatively easy to perform, and they are most commonly used methods in most of the laboratories that we have. It can also be automated. An advantage of it is that we don't require a separate instrument to use these methods. For HPLC, we need a separate instrument. Limitation of it is that results can vary based on the specific assay and the presence of hemoglobin variants. Again, HPLC has the ability to pick up the variant hemoglobins, which we lack in the immunoassay and enzymatic methods. So we've read about all these methods. So what is the most cost-effective method? It basically depends on what kind of a setup you have. See, the first tier hospital like medical colleges or maybe a huge hospital which has all the resources and which has financially and technicality wise they are well equipped. So in those cases, HPLC being the gold standard is the most preferred method. Enzymatic, immunoassay, and affinity chromatography, they can be used as a supplementary method. Enzymatic method is again more cost effective, but then if you're talking about a first tier, tier A hospital, then we'll obviously have those resources where we can study the hemoglobin variants. We are responsible for giving out high quality results. So maybe in those setup, HPLC would be the most preferred method. But moving on to maybe a tier B or a tier C city, we've been talking yesterday regarding the various challenges that we see in maybe a low resourceful lab or where there are financial restrictions and there are limitations. In those cases, maybe immunoassay or enzymatic method may be the most preferable method, because your basic task is to maybe report HbA1c and all the abnormal samples or in which we have doubts or in which there are variants, they can be referred to a higher center. So in a second tier hospital, high quality results are obviously the priority, but you may not have the technicalities to distinguish between the variants, or that might not be the need at that time, at that point of source. So in those areas, in those hospitals, in enzymatic or immunoassay I think would be fine. And in a tier C city, where basically the routine labs and the basic reporting is to be done, in those cases, again, enzymatic and immunoassay can be used. POCT is another thing that is coming up, but it has its own limitations. It lacks accuracy, reliability, and most importantly, it doesn't have standardization and established quality methods, basically. So you cannot actually rely on the report. So that was all about HbA1c. I'll just touch briefly on other marker. One important marker actually that is important, that is fructosamine. Like HbA1c binds to hemoglobin present in the RBCs. Like glucose binds with HbA1c. I'm so sorry again. Like glucose binds with the hemoglobin present in the RBCs to form HbA1c. If glucose binds to primarily albumin, that is protein present in the blood, that forms fructosamine. Method of testing is again HPLC, and its normal range would be around 200 to 300 micromole per liter. It may vary according to the testing methods of laboratories. Why fructosamine is important? Because we know HbA1c is for long-term monitoring, but in cases where there is a rapidly changing glucose levels, maybe a clinician has a patient and the clinician has to titrate the dose of the patient. He's undergoing intensive insulin therapy, or there is a recent change in medication. In those conditions, we need short-term glucose monitoring. For HbA1c is for 3 months. For fructose, we can do it for 2 to 3 weeks. So short-term glucose monitoring can be a clinical application for fructosamine. Another alternate, it can be an alternative in HbA1c as in anemia, hemoglobinopathies, pregnancy. We had a session yesterday on gestational diabetes mellitus, where it was emphasized that for GDM, HbA1c is not to be used. We do OGTT and fasting blood sugar. So in anemia cases, in pregnancy cases specifically, fructosamine can be used as an alternative. Then post-surgery or illness, like after surgery or during any acute illness, HbA1c is not representative of the current glucose levels. In these conditions, fructosamine is a better alternative. Then assessment of new treatments, it helps evaluate the effectiveness of new diabetes medications or lifestyle changes over a shorter time frame. Again, when we need to assess a shorter time frame, basically, if we need to understand the metabolism of glucose, basically effects of glucose over a shorter time frame, then we can go with fructosamine. Again, it has its limitations. Fructosamine can be affected by changes in protein levels in the blood, such as nephrotic syndrome or significant weight loss. That being said, fructosamine is not a replacement. It is useful in certain conditions, but it should not replace HbA1c testing entirely. Other than fructosamine, we can use C-peptide and glycated albumin. C-peptide is basically, it indicates insulin production by the pancreas, and it distinguishes between type 1 and type 2 diabetes and assesses beta cell function. Fasting levels of it are preferred, and the normal range is between 0.5 to 2. It may vary within labs. Then glycated hemoglobin measures glycated albumin levels. It provides information on blood glucose control over the past 2 to 3 weeks. Method can be done by HPLC or immunoassay, and the normal range is less than 14 to 16%. To conclude, HPLC remains the gold standard against which all other methods are compared. But then again, that being said, you have to understand your requirement and the kind of lab you're dealing with. What are your requirements and what are the limitations that you have? The cost effectiveness, the number of samples, the availability of a pathologist who is trained enough to read the graphs and the variants. So it depends on that. It depends, basically, it's a need-based approach. Advantages of HbA1 testing is long-term monitoring. There is reduced daily variability, standardized measurements, predictive of complications, and there is guidance of treatment adjustments. Convenient and a relatively simple test, but that goes with both immunoassay as well as enzymatic methods. Limitations of HbA1c would be influencing hemoglobin variants. It is misleading in pregnancy and in anemic patients, and delayed response to changes in glucose levels. For all these limitations and for a shorter time frame, you can consider fructosamine, but HPLC still remains the gold standard. Thank you. Mudit.
Thank you, Doctor, for your excellent presentations on glycated hemoglobin as well as fructosamine. Now I'm opening this topic for your discussion.
Dr. Mudita, thank you. That was a very comprehensive talk. I wanted to seek your opinion because it's a challenge I face also in practice every day. When we are writing the reference range for HbA1c in the report, do you use the cutoff of 5.7 or 6.3? Because my predicament where I'm stuck is that pre-diabetes based on HbA1c is not present in WHO definition. It is a ADA definition. Now, I've always been stuck whether to go, I have always chosen to prefer WHO because I find ADA a little more pharmacologically motivated and WHO to be more balanced. So, do you, when you are using, do you use the reference range of 5.7 in your report? So, fasting glucose also you are following ADA or it's pick and choose?
So actually, it basically depends on what the clinician demands, what the clinician is following as his method of treating the patient, because we sign out the reports, but eventually it is the clinician who decides, okay, no, I will consider this as the pre-diabetic range. So it basically actually depends on the
I
clinician we are
totally
signing
agree.
out the report to.
He will choose whatever I write it as. Even if I'm writing 6.3 as normal, if he has to choose, he'll choose. So how you are making the selection? I have been very confused about it. I just wanted to seek your opinion.
Sir, in HbA1c, as of now, the consensus is what the IFCC says as per the methods and the range. I would actually go with this, the range that I mentioned, because HbA1c has a long history of for standardization. There has been a lot of, even for, in fact, even HPLC, they say is the standard method, but there are studies in Sweden and Norway who are using the same HPLC method, but then they were not giving the same result for the same samples. So I'm sure they must have definitely gone through a vigorous sort of session to fixate on this key, okay, this to say that this is the gold standard. So I actually trust them with this. And again, you may sign out the report as whatever range that you think according to your lab is. But at the end of the day, it's the clinician who decides. I might say, oh, the person has 7% HbA1c, so he is a diagnostic of diabetes. But then the clinician would argue with me, no, there are no signs and symptoms, and then there are other tests which are not correlating with it. So maybe I will not consider it as 7% as diabetes. So it basically, it varies with person to person and with the clinician's demands.
In HPLC based methods, there is the one big problem is interference and spurious results. I just want to share an opinion about one of the things in your slide. I would request you as a colleague, you had written in a second tier hospital, professional person not available to analyze the graph. I believe if there is not a person to analyze a report, there should be no analyzer to do the test. If there is, if any test, any methodology is being used, it should have a professional person to report it.
That is why I mentioned maybe in a tier we use
No,
immunoassay.
if there is, we should not write it. I feel because it's a kind of we are accepting such a thing can happen. We should. It's like if there is no person running the machine or reporting result is kind of, in my opinion, should be illegal or currently also considered a crime because you are playing with someone's life. So we should not accept that to happen.
I have a question, Dr. Makita.
Yes.
Thank you so much. Excellent presentation. Just for the sake of my learning, I want to understand. Now, is there any study done between GHbA1c and HbA1c?
So, right, as of now, I'm not aware of it, but then it's a good question. I'll actually read up on it and get back to you.
All
if
right.
I can.
Because, Dr. Vishu, why I'm asking this question? Because there's a methodology. There's only one method in the world which is absolutely hemoglobinopathy free for HbA1c is mass spectrometry. There's nothing else. Now, mass spectrometry commercially not possible because it's very expensive. The next comes, the boronate affinity. Now, this boronate affinity is the place, the technology, where actually every glucose, anytime, any glucose molecule getting attached with all the N terminals, whether it is a beta chain, alpha chain, gamma chain, delta chain. In A1C, when you are doing with ion exchange chromatography, you are actually focusing only on the beta chain. What about the alpha chain, gamma chain, delta chain? We are not taking it. Whereas in boronate affinity, actually you are able to take the glycated segment, the complete glycated segment. You are actually taking out the glycated and non-glycated. So the quantum, because I've seen a lot of difference between the results in GHB1C and A1C. That probably helps in eliminating a lot of errors. But unfortunately, why this method is not popular? It's there, it's available. I'm talking about chromatography, this kind of systems are available. But in absence of studies, probably these queries are coming. And Dr. Vishu, to answer your query, in the A1C, when we talk about the lot of variations, and you really cannot go with one A1C report. But if you think about GHB1C from the boronate affinity method, you'll find a very consistent result, and the normal range for that is different. That's I know about it because I was in Switzerland, those days working with somebody. Though I'm not I'm from this background, but I've done little bit of working on A1C, on particularly GHB1C. I found that method is better. Yeah, like it did. Yeah. 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 Yeah.
That what we understand and see, we are discussing in the forums. The clinicians' understanding of that is very less. Two, their acceptability of the explain also is very less.
So we have to stick to a method which is why GHB is not so popular. A1C has come because everybody is doing that. Because for a patient of diabetes, the serial monitoring, either it's like, say, it's like an Apple and a Samsung.
Yeah.
Okay. If you are an Apple user, stick to Apple. You are happy with the chain going on forever.
Yeah.
Then Androids is going that way. Likewise, a patient who's doing his monitoring on GHB, he can't go like January GHB
Yeah.
वाला
I
कराऊंगा,
understand.
June में A1C वाला कराऊंगा.
Understood.
His treatment would get haywire. And the most why HbA1c is really important for human life is it's a parameter which is monitoring and managing diabetes. Diabetes is one disease which is the mother of almost a lot of other diseases. If patient's diabetes is not properly monitored, although lab is only the 1% or maybe 0.1% reason in that, 99% is the patient's behavior themselves. But it is the originator for everything.
Yes.
For your MI, stroke, CKD. If you look at these, they have increased in number because of diabetes increase and poor management. So while doing HbA1c, selecting the technology more than accuracy, also accuracy is definitely there. We choose the accurate method, we choose the accurate equipment, we calibrate, run QC very stringently. However, sticking to a line which is good for the patient, I should not add a confusion to him or the clinician, because even the patient is just following the doctor. And trust me, most of the doctors, they are only endocrinologists who are actually dwelling deep into the technology methodology used. However, even in a city like Delhi, there are hardly 10% of patients who would be going to an endocrinologist for diabetes. Majority load is managed by GPs and MD medicines, internal medicine. So they don't go that deep. And then also comes in the homeopaths and Ayurveds and reversal diabetes. A diabetic patient tries everything under the roof. But laboratory is his best friend in that, which he learns. And for laboratory also, see, the chemistry business is all about NCD, non-communicable diseases. That's the biggest strength point in chemistry. So we have to be very conscious. We have to think what our patient needs than what we think is the best.
I have a question on this method also, because it is measuring the 3 months period glycation. So I have seen many patients with the 200 milligram of glucose reported with the 6.2 of HbA1c. So this type of things, I don't think it's a pure indicator of diabetes first. And there is a huge hue and cry about the HbA1c of 7 to 8.5%. So in this range between, there is a lot of confusion with the different instruments. Tosho is claiming that they are doing the best HPLC, whereas other equipments are also doing. There is a huge lot of variation between the price of all the equipments. So I want to ask this forum whether which is the best method for doing the HPLC, by the Tosho or by other equipments, because they say their method is not HPLC, there is something else. And other point is, what is the difference between 7 and 8.5 of HbA1c value?
So
Is there much difference if the patient is having HbA1c of 7 and the same patient is having 8.5?
So I think the higher, answering your first question, I think every machine will have different methods and they will have their own separate ranges. But I think the only solution it is if you're getting it tested from one lab basically, or one certain method, then I think the follow-up tests should also be done from the same method, because that is the only way you can have like a conformity. Because even the clinicians, I think they say if you're getting it done from one lab, then get the repeat follow-up test also from the same lab. So even if inter-lab variation is there between instruments, the same instrument on day one will obviously give us like the method of working would be the same even after 3 months. So to avoid that conflict, I think like all clinicians also advise, like we also advise, if you're getting a test done for follow up or for monitoring, it's always better to get it done from the same lab or from the same machine, or any machine that is following the same method. So I think that would in a way resolve conflict of different labs having different methods and different ranges. I think that would sort of solve that conflict up to a certain extent. And as far as 7.5 and 8 is concerned, I think above the cutoff, I don't think the clinicians or the endocrinologists, I'm sure there must be studies where they have sort of graded the range into different complications, like as per the increase in like whatever, like what you're saying, 7 to 7.5 and then 7 to 7.5 to 8. I'm sure there must be numerous studies being done, but I'm not aware of it as of now. I'll look it up, sir, and I'll get back to you.
So regarding your question only, I want to suggest you one thing, whenever the companies are claiming that we are doing XYZ and all, first you verify their claim, because you are the best judge on that. You have the work experience of working with so many years on so many machines. So you are the best person to understand, whether whatever they are claiming is actually like in the NABL also we have the same thing, that first whatever they are claiming we are verifying at the lab level. So you do your linearity study, you do your linearity regression curve analysis and see how much CV percent they are giving. And if your CV percent are coming in that appropriate range based on your population and your data of your lab, like what type of people you are having, like more of a diabetic or the elderly population or most of the young population, I think then you will come to that standardization, that whether this machine is good to select or that machine is good. And
CV% is 1% in most of the machines. And the problem is that there is a huge difference in the cost of the machines. One is costing 5 lakhs, other is costing 10 lakhs. The running cost is very high. Third is the machine is doing only HPLC. And we face so many problems with the HbA1c because there is by the endocrinologist, there's a huge cry. If the same patient I am giving the 7%, other day I am giving 8.5%. So they make a huge lot of huge. Yeah.
In that kind of situation, I was asking rather, not suggesting, I was asking from you people that why not we talk about the glycated. So glycated always
Because HbA1c is so much popular that you can't negate it. Yeah, maybe
No,
the very time when the problems will arise so much that they are totally dependent upon HbA1c. Why not on the fasting and PP sugar? Better to rely on that instead of relying on HbA1c, which is very dubious. It can come down, it can go up. You don't know.
Because if the HbA1c remains in at the range of 7%, the cardiorenal complications over next 2 decades, it's 10%. But at 9 HbA1c, in 10 years, there is a 70% people develop cardiorenal complications. So that 7 and 9 is the difference of life and death nearly. Two, so you asked the best equipment. Let me explain you. So whether you talk about HbA1c, thyroid, sugar, anything, there is nothing known as the best equipment. Every equipment has its goods and bads. We have to see what fits in our lab. All technologies are good, but you have to understand which one is suiting your lab. Everyone has its pitfall, and you get a equipment today, that's the best equipment, best technology, but it will not give you the best result. What all companies talk about, no offense, They talk about the best technology. You and I talk about the accurate result. They are two different things. So equipment is giving you a value. Giving out the right results depends on how you are managing your equipment, how you're doing the quality control, and how you are interpreting the report. I many a times find various results which don't correlate. I'm unable to understand how is that happening. But I check it over 2 or 3 technologies and I see the results coming same. Then probably I go back to the book and I speak to the clinician that can you explain me what's happening exactly with this patient? For instance, I think at least 3 to 4 times a week, I am seeing recently patients with HbA1c of 5.5, 5.6, not even in the pre-diabetic range, with fasting or PP sugars more than 200.
Yeah, same.
But I'm checking it across technologies. It's coming the same, even the sugars, even the A1C, all technologies. But that is the value. Now, the problem is not the machine. You have to understand what's the disease going on. Everything will not fall in the same books because 20 years later, impaired fasting glucose, or maybe 30 years later, it was not recognized. So there are new things, changes coming. From a lot of patients where I found the answer from the clinician is that they have recently started on steroids or with regular health checkups. Earlier, what was happened that people were getting health checkups like what? Once in a year, 2 years, or never. So people, by the time they used to detect their diabetes, their HbA1c would be at 12, 13, 14. But now there are certain patients we're seeing, when I see in the follow-up, 6 months later, I'm finding his HbA1c to be raised. But before, within the 3 month period, he got the health checkup done. His sugars were high recently. The change came in just last month. I'm seeing those patterns. So there is no technology issue. You have to understand the patient disease also.
So what I want to point out is the HbA1c is the gold standard for the diabetic diagnosis. I think it should be changed, and it should be changed to some marker like you mentioned, GHB, so that the time frame should be reduced, like a fructosamine, which is taking care of 4 weeks only.
Can
So
I just
these things-
answer to this question?
Yes, sir.
See, we have a big threat in our community of clinical chemistry that we have multiple equipments across and multiple technologies available. See, the ISO is working on, the standardization organizations are working on something called commutability. If you have noticed, it is there in the ISO 15189 2022 standards. There is a non-difference between equipments, technologies. The international community has recognized that there is difference and it has to be corrected. So this correction is a common requirement by everybody. It's for the patient safety factor, not to say that that equipment is good or this methodology is good. Commutability has to be there. That means anything that is measured should give the absolute value so that clinician will be able to create a sensible decision that will improve the patient safety. So this discussion has no meaning, but because it not only affects HbA1c, it affects all the parameters. Okay.
I will, as expert in hematology, I would like to add a clinical management of the patients with abnormal hemoglobin A1c. The fact is, we know that this group have especially risk of thrombosis and neuropathy. And the thing is, for me, it's important to know when the patient really is going to have this complication. The neuropathy, we cannot do it from the analytical part, but we can do it from one important parameter that is not related to the glucose, that is the D-dimer. My experience, when we know that the patient is not equilibrated and is going to have symptoms that really will affect the risk of death, is when increase of D-dimer. And managing the D-dimer is also another parameter that will help us to manage this patient and to avoid the risk of thrombosis or the risk of neuropathy, even because they come together and the blindness. But the coagulation can help us also to know when a patient is really going to have problems. From the ones that have glycosylated hemoglobin that is high, but you don't know if really is going to have a risk. Just to remind that hematology or coagulation in this case, we can help you in the management of this patient.
I also agree that, and the response to the HbA1c value is not similar to every patient. There is some genetical difference also. That somebody who is having a very high HbA1c may not generate the same effect that another person who is having high. And there are new tests that are coming like that post-pancreal increase in blood glucose. We don't know exactly whether HbA1c is a real marker that can be looked at this stage.
Yes, madam, anything you want to add on?
Thank you.
Yes. Before concluding the session, just three important discussions were going on related to this topic. One is about the cutoff values. As of now, American Diabetic Association has given us very clear cutoff regarding the values. In a non-pregnant and non-anemic general population, the values are very clear. There is no doubt about it. If it is the HbA1c levels are less than 5.5, he is non-diabetic. If it is between 5.5 and 6.4, we can call it as a pre-diabetic or impaired glucose tolerance. More than 6.5 is clear-cut diabetes. There is no doubt about it. But they recommend each and every laboratory, not the country or ethnic group, each and every laboratory should have their own cutoff ranges for their particular population. This is what the recommendation when it comes related to the reference values. First one. Second, regarding the methodology, we have some 5-6 methods by which the HbA1c can be estimated, starting from the HPLC method, then capillary electrophoresis, as Sir mentioned, borate affinity chromatography method, which is nothing but an ion exchange, immunoturbidometry method, and enzymatic method. Among all these methods, as of now, the NGSP certified methods are only two. That is, one is HPLC and another one is capillary electrophoresis method. So you should follow any one of these methods for the estimation of HbA1c. Then only your method, your reports are validated. And even if you are going for publications, the instrument which has the NGSP certified, validated values are only accepted. No other methods are accepted. If you have any shortfall in these instruments or methodology, please go with your plasma glucose level. There is nothing that only HbA1c is the gold standard for the diagnosis of diabetes. No, because HbA1c has its own limitations, like anemia and a lot of other things, cost effective, especially in a government setup, and even it is availability. It is there only in the metro cities. What about the rural areas? No one knows about HPLC or HbA1c. Where you have a plasma glucose, fasting and postprandial is very much enough for the diagnosis of diabetes. So HbA1c is an alternate. If you have availability and affordability, please go with HbA1c, HPLC, your HbA1c. Or otherwise, please go with your plasma glucose level. Very cost effective, and even you can repeat it every 2 weeks, which you cannot do with your HbA1c. So this is about the methodology. The third discussion, which was going about the equivalence between your plasma glucose as well as your HbA1c level. See, we take a sample. One sample you are dropping it into your EDTA tube for HbA1c. The other same sample you are putting it to your red cap, that is for glucose estimation. You are analyzing in your lab, your glucose value is 140 milligram, whereas for the same patient, the same time collection, HbA1c is 8. How you will compare this? Both are correct. Both are correct. Or your fluoride tube, whatever it is. Fluoride tube you are putting, there it is 140 milligram. Here your HbA1c is 8.5%. It is not analytical error. Practically it is correct because you would have given insulin last night. Yes, so never ever compare your plasma glucose with your HbA1c. Okay, if you are going with HbA1c, go with HbA1c. Yes. That is what. So your plasma glucose vary time to time. That is why you are going for HbA1c. So if you are going with plasma glucose is as your therapeutic target, please follow your plasma glucose. Or you are going with HbA1c, please go with your HbA1c. The average value, this and that, what they are giving is not correct. Yes. I have not much exposure with that. Yes. That I think if any further discussion on HbA1c, we can very well take it about during our lunch.
Yeah.
Lunch
So in
time.
the interest of time, may I request, yeah, everybody to like, we have limited time and everybody has to go back today. So we can discuss over lunch if there are any questions.
Thank you, ma'am, for opening important as well as interesting
Yeah.
topic.
Okay. So may I request Dr. Vinaya Murthy to please felicitate our speaker. Thank you, sir. Thank you, Dr. Mudita. May I call the next speaker on stage, Dr. Rahul Goyal? And may I request Dr. RJ Matthew again to please chair the session, please?
I feel proud to introduce Dr. Rahul Goyal, who is from Raghav Diagnostic Center, Gurgaon, who is speaking on the topic significance of ADA and ACE markers in biochemistry. I still remember these two markers are recently came, which is recent, quite oftenly used in medical colleges and hospitals. So he is presently working as lab director at Raghav Diagnostic and managing director at Health County Private Limited at Gurgaon. He is having more than 10 years of experience in clinical laboratory as in quality and accreditation. He is currently working as coordinator for numerous NABL, CAP, and NABH audits. He has past affiliation as lab director at LFS Healthcare and consulted at Diagnod Labs, Gurgaon. And he has more than 10 national paper publication, and he has been speaker for many CMAs. Over to you, Dr. Rahul.
Thank you, sir. Thank you, Mindray, for inviting me over here. Today, my topic is significance of ADA and ACE marker in biochemistry. Both ACE and ADA, these both are the key indicators used to assess physiological and pathological states in the body. ADA and ACE, both are these two enzymes have significant roles in diagnosing and monitoring various conditions. Now we come on to ADA. What is ADA? ADA is an enzyme involved in the purine salvage pathway, converting adenosine to inosine. ADA is a dimeric enzyme existing in two major isoforms, ADA1 and ADA2. Now we can come on to ADA in Indian context. ADA is most crucial for the diagnosis of tuberculosis. There is high incidence of TB in India, one of the highest globally. Elevated ADA level in pleural fluid are used as a diagnostic marker for TB pleuritis. High sensitivity and specificity makes it a useful test in differentiating between TB and other type of pleural effusion. This is a report of Global Tuberculosis Report 2023 presented by WHO. It shows an estimated global total of 10.6 million people fell ill with TB in 2022, equivalent to 133 incident cases per 1 lakh population. India is ranked 1 in this in terms of number of cases. Now we come on to the current diagnostic method of tuberculosis. There are basically two current methods, direct microscopy and culture. In direct microscopy have low sensitivity, due to which we have false negative results. It needs a higher bacterial loads. In culture has slow growth of mycobacterium. It is expensive, needs technical demands, and low identification rate of bacilli in extrapulmonary TB cases. This is the first study which is published in 1984. This research article highlighting the significance of ADA in tuberculosis. This early work established ADA as a valuable diagnostic marker for distinguishing tuberculosis distinguishing tubercular pleural effusion from other causes of effusion. This study investigated the level of ADA in pleural fluid from patient with tuberculous pleurisy and compared with them those from patient with other type of pleural effusion. This research found that ADA levels were significantly elevated in TB patients. Now we come on to the question, why ADA is ideal marker for TB pleuritis? For detecting mycobacteria in pleural fluid, which can be difficult because there may be a large volume of fluid, but bacterial load can be very low. Though the ADA test is not specific and does not replace the culture for diagnosing TB, but it may be a positive even when number of bacteria are very low. It can be used as an adjunct test to help determine whether tuberculosis is the likely source of patient syndrome. ADA testing, therefore, is widely used in India due to its cost effectiveness and reliability. The principle of ADA is enzymatic assay method. Any fluid, serum, or plasma can be used as sample type. For quality control, calibration and validation is need to be done like any other biochemical parameter. Diagnostic cutoff of ADA is less than 40 units per liter. This value is used as a guideline to help differentiate tuberculous pleural effusion from other type of effusions. ADA level above this cutoff are typically considered indicative of TB. Now, advantages of ADA testing. First of all, ADA is cost effective. It has relatively low cost compared to other diagnostic methods. Second, accessibility. It is widely available and it can be easy to perform in various healthcare settings. And early diagnosis. It helps in early detection of TB, especially in pleural cases. Limitations of ADA. The limitations include non-specificity. Elevated ADA can occur in other conditions such as lymphoma and sarcoidosis. And diagnostic accuracy. ADA should be used in conjunction with other diagnostic tests for accurate diagnosis. It cannot be used alone. Now we come on to angiotensin converting enzyme, ACE. What is ACE? ACE is an enzyme that converts angiotensin 1 to angiotensin 2, a peptide involved in blood pressure regulation and fluid balance. Structure. ACE is a zinc-dependent metallopeptidase found in endothelial cells or blood vessels. Now, clinical significance of ACE. ACE inhibitors, which can be used in hypertension. Medication that inhibit ACE are commonly used to treat high blood pressure and heart failure by preventing the formation of angiotensin 2. In genetic conditions like variants in the ACE gene can influence the enzyme's activity and have been linked to cardiovascular diseases, including hypertension and heart failure. Sarcoidosis. ACE level in sarcoidosis can be elevated, which is a characteristic marker. In diagnostic and monitoring tool, ACE levels can help in diagnosis and monitoring of the disease. And in other conditions, altered ACE activity has been observed in diabetic patients, suggesting a role in diabetic nephropathy. Normal value of ADA is less than 40 nanomole per ml per minute. Principle is enzymatic assay method. Fresh sample and plasma can be used as a sample. And in quality control, calibration and validation is required as same as other biochemical parameters. Now to conclude, ADA and ACE are vital biochemical markers with specific roles in health and disease. Understanding their functions and significance helps in diagnosing and managing various medical conditions, improving patient care and outcomes. Thank you.
Thank you, Dr. Rahul, for that quick capture on two important topics of ADA and ACA. Now the forum is open for questions.
So basically, ACE done for the diagnosis of the hypertension or what?
For sarcoidosis, sir.
Sarcoidosis, it's diagnostic.
Yeah.
This is why ACE level altered in sarcoidosis. Now, because this is the test which is being used for about a decade now. just the scientific basis. We are not using it for any other granulomatous disease except for sarcoidosis.
Sarcoidosis. Basically, sir, there is change in endothelial cells activity in lungs in sarcoidosis cases. So that can be a reason which due to which altered ACE level can be seen.
Please understand, we are in a very high endemic country which has a very high prevalence of tuberculosis. Okay, and all government, as per the whatever studies has been carried out in India, now even though we are discussing it in a biochemical forum, but ADA level is no more advocated for the TB diagnosis. We have CBNAT testing available at every corner of the country. Even the TrueNAT services are available at all the corners of this country. So we should go for the molecular diagnosis of TB, and that is where we have headed already as a whole country, because we have a kind of very ambitious goal of elimination of tuberculosis by 2025. So, I mean, that is where we are heading towards. So, we have to understand that it's a very, and now we are like struggling with the further question of diagnosis of latent and subclinical tuberculosis, because TB is not. Earlier, we used to say that it's a disease of lower socioeconomic and all, but now you see in all classes of society, you are getting tuberculosis, you know. So it has no more remained as a socio-economical burden. But, you know, it is a very complex disease to deal with, because even in the higher society, they are getting the maids and the servants which belong to the lower society. So the children, they are getting the tuberculosis through those maids and everything. So we have to understand the complexity of the disease and follow the national guidelines, because now our guidelines are becoming more and more adaptable, and the available infrastructure at the lowest part of the city has been upgraded, because you see CBNAT machine is now available at the district level. TrueNats are available at the sub-district level and almost everywhere in this country. So that is where we should be thinking of tuberculosis, you know.
I'm totally agree with you, but I think there is the thing awareness which is required in the patients. Everyone is not aware, as you said, that CBNet or TrueNet is available at the district hospital center. Especially in my city, from where I came, no government setup has these tests. The clinician has to depend on the private labs only, and in private lab it is a very costly test. So not every patient can afford CBNet or TrueNet. So that is the reason ADA can be used as a diagnostic tool.
See, I just
I believe that those tests that are done by the government organization for TB are free. Free. So that may not be the valid reason, but still I agree that ADA can be a guidance to those tests.
see the molecular tests, as we say, are available now for almost all bacterial diseases. You
Yes,
put the sample into the machine and it gives you the result. And these are based on the various molecules or the amino acid thing. Is NGS available for tuberculosis?
Yes.
It is available. If it is available, what is the cost?
Cost is high.
Okay. No, my point is that whenever we have a case of meningitis or a pneumonia, we want to treat it immediately and start the antibiotics, or any case of septicemia. That hurry is not there as far as tuberculosis is concerned.
Yes, sir.
It is not an emergency condition. So maybe you can devise or modify the test in such a way that it may take 1 day or it may take 2 days, but let the cost come down to around about 1,000 or so.
So if there are no questions, TB is a very big topic for debate. No, there are a lot of studies, investment by government has been taken place on the ADA is definitely a test of interest that will give a guidance for the test. Even the TrueNat or the gene expert, that is not 100% false proof in case of diagnosis of TB. Probably NGS may be the only future that we are looking at. And we are open to create new tests and discover new things that can precisely diagnose the disease. Shall we close the session if there is no other further question? Thank you, Dr.
Yeah.
Rao.
Thank you, sir.
Thank you. Thank you, Dr. Rahul. And may I request Dr. Riju to please felicitate the speaker? Thank you. Thank you very much. So before we depart, a heartfelt thanks to everyone. It is an honor and privilege to have you all here. And it was an exciting gathering of pathologists, hematologists, and leaders in this medical fraternity. On behalf of Mindray, BLK Max, ACC LMP, IFCC, I stand here and extend our deepest gratitude to all who have made this journey possible. We would like to thank our esteemed speakers, moderators for sharing their valuable time and expertise. We also deeply we are also deeply grateful to our channel partners, collaborators, and organizing teams whose timeless and tireless efforts have made Cube and SFCC 2024 possible. I would like to thank the event partners, Prime Entertainers, my entire team Mindray to run the uh, 3-day event seamlessly. A special thank a special thank to a special person, Dr. Ramon and Dr. Venkatesh Thuppil, who for sharing their prestigious knowledge. I would like to mention here Dr. Ramon has flown from Switzerland, especially for this 3-day event to share his knowledge and give back to the society. As well, Dr. Venkatesh, I just gave him a phone call and he accepted my invitation, and I was really grateful to Dr. Venkatesh because these are the people who will now give back to the society, and the youngsters should take this prestigious thing from them. I have just made notes so I don't forget any name. So this is, I would like to say this is more than an event. It's a gathering and it's an opportunity to connect, learn, and contribute to the advancements of the fields, especially like chemistry, CLIA, and hematology. And with this, I end my with gratitude. I end my Thanksgiving. Thank you, everyone. Thank you very much. Yeah, I have to extend this.
Let me ask also for a big applause for Xama. She was.
Thank you so much, Dr. Rahman. Thank you so much.
The certificates will be available
We will
online.
have lunch in the restaurant downstairs. So I would request everyone to have lunch and then like we have a car drop. So then we can all depart with a heavy heart. Like we are all departing, but we are all connected. It's a small world. Thank you, everyone.
to give this presentation on with the name innovations in immunoassays, transforming diagnostic.
A special mention here, I just simply forgot, and I want to thank with deep gratitude Dr. Tajinder Singh, who is our legend in hematology. And I was just speaking to Dr. Tajinder Singh the other day. We would like to have one of his book, which I had gone through on the net, and he has told us that he will like I can talk to the publisher and we will get it in some concession. So, oh, so nice. Thank you. Thank you, sir. Exactly, sir. So it's really good of him to like give us that book. Actually, I was planning to give that book as a gift to everyone. So for next cube, I asked him that we will give that book as a gift to everyone. Yes, yes. Thank you. Thank you so much, sir.
Thank you.
Thank you.
Good afternoon, ladies and gentlemen. It is my great honor to give this presentation on with the name innovations in immunoassays, transforming diagnostic capabilities in India with Mindray CLIA solutions. My name is China from Mindray, and today I will take around 15 minutes to share something new of Mindray CLIA solutions. So let's start the journey to explore more. And my presentation include two parts: Mindray CLIA analyzer family and Mindray CLIA solution and innovations. So, okay, for the first session, I would like to share with you more information about the entire family of Mindray CLIA analyzers and the innovations utilized on them. Our CLIA analyzer family includes a variety of different analyzers that are designed to meet the needs of different types of labs, from small clinics and hospitals to large reference and chain labs, making it versatile and adaptable to the range of laboratory settings. It could be compact and efficient for small and decentralized labs. It also could be ideal for high volume and complexity labs. So we'll dive into the portfolio from the right upper corner TLA to the benchtop units. For Tier A solution, we have two different lines, M6000 and the TM8000. Both of them combine pre-analytical, analytical, and post-analytical parts, like sample input, transportation, dispenser, decapper module, etc., etc. Well, for analytical part, not only could immunoassay and chemistry be connected, but also hematology, coagulation, and urine analyzers. Until now, there are more than 100 MT8000 lines installed in China, and which accounted a big market share. We also have integration system for big-sized lab. It can help streamline laboratory operations, improve efficiency, and ensure accurate and reliable test results by integrating chemistry and immunoassay different modules together. The latest version of integrated analyzers are M680, M980, and M1000, and we call them 3M new platforms. They reflect the high throughput and intelligence simultaneously, which are utilizing full scene sampling track and ultrasound vortex mixing technology. So what are the full scene sampling and ultrasound vortex mixing technology? Based on the analysis of abnormal characteristics of a large number of data during sampling, For example, static abnormality, bubbles, clots. The analyzer can distinguish the abnormal samples to ensure the accuracy of sampling. So thanks to this new technology, it can help identify sample containers based on the databases and algorithms. It can also help improve the accuracy of sample aspiration and eliminate the risk of samples and reagent bubbles, which ensure more accurate test results. Ultrasonic vortex mixing is one of the innovations of our CLIA platforms. Most of analyzers are using the old mixing method, like just shaking or vortex. Here, ultrasound vortex mixing is utilized to our CLIA platform to remove the non-specific binding and reduce the interference of fibrin clot in serum, and then enhance the accuracy of the result, especially for high-sensitive assays, such as high-sensitivity troponin I. Regarding to medium labs, I would like to share with you the latest standalone unit, CL2600I, with the same throughput of CL2000I, but very small footprint, less than 1 square meter. It also uses SF sampling technology. Besides, there is a network of 85 sensor groups, which are monitoring the whole process of testing of the analyzer, from sampling to the measurement, in order to ensure excellent performance. Actually, we pay attention to every segment. So except for solution to the central lab and the medium, big labs, we also have solutions for small labs as well. The benchtop size analyzers, which are compact but effective. CL900I is the star product launched in 2018. It's maintenance-free and cost reductive. CL1000I with bigger capacity for sample and reagent, user-friendly and powerful. With all these different solutions, we can benefit all customers with different needs. Okay, for the second session, I would like to share with you the core competitiveness of Mindray immunoassay from the voice of our customers and R&D investment as well. Next, let's move to the main focus, Mindray CLIA solutions and innovations to show you a full picture of what we have and what kind of solutions and innovations we can bring to your lab. Okay, up to now, totally we have 89 assays in our test menu, including 16 panels, which we can provide to our customers. And we are expecting another 10 new parameters within this year, which are highlighted in red. Then totally the number can reach around 100. Let me give some detailed introduction on some star panels. Okay. When we refer cardiac panel, we are emphasizing more on raw materials. So after the successful integration of high-test, we are trying to enhance the raw material innovation, expand the test menu, keep improving reagent quality. Cardiac panel is the blood test that can provide valuable information for doctors to diagnose and treat heart conditions. It is the first star panel construction fruit after a high-test acquisition. This year, we launched the high-sensitivity troponin I and NT-proBNP, and we are expecting another new parameter, ST2. So when we talk about the whole target structure and antigen structure, firstly, we should know the potential targeted molecules. And we could detect in the blood circulation in a myocardial infarction patient. Actually, high-test found out that over 90% troponin I are troponin IC and troponin ITC complex. So detect the troponin IC and troponin ITC complex can effectively avoid false negativity, then improve accuracy. And also we use IC monoclonal antibody design to improve IC sensitivity and specificity. For the analytical sensitivity of Mandarin high sensitivity troponin I listed in this table, the actual performance is much better than we announced in the IFU and better than that of our competitors as well. The overall detection rate in healthy people population between LOD to the 99th percentile, 99% of males and 87% of females, which meet the recommendation of AACC and IFCC guidelines. Furthermore, in the face of real scenarios, we conducted continuously research in 6 hospitals and all scenarios. Among nearly 14,000 samples, and our overall anti-interference probability is less than 0.01. Besides, we carried out some evaluations both in China and in the US. The slide shows that evaluations in the US, the results have been exhibited on AACC 2023, which is conducted in Minneapolis, the USA, to verify the analytical performance of Mandarin high sensitivity troponin I immunoassay. And Professor Fred Apple, who is one of the most famous experts on heart disease, gave a very positive comment on the analytical performance of Mandarin high sensitivity troponin I. The second evaluation is at Wuhan Asian Heart Hospital in China. The scientific paper is available online, and the conclusion of the study is Mandarin high sensitivity troponin I satisfies the definition of high sensitivity troponin. It delivers excellent precision, sensitivity, and specificity, and it demonstrated excellent performance in clinical diagnosis, providing high level of accuracy and safety. Another study is from Professor Lippi at University Hospital Verona in Italy. And the conclusion of the study is Mandarin high sensitivity troponin I immunoassay on CL1200I demonstrated that the overall performance is comparable to that of other commercial available high sensitivity troponin I techniques, making it a viable alternative to other methods. I also want to share some ongoing clinical studies with you, which are doing the research on 0-2-hour algorithm for rapid diagnosis in China, the US, the US, and Italy. Meanwhile, we are conducting a clinical study on risk stratification of cardiovascular events in special populations. Moreover, we are trying to establish pediatric reference ranges for Mandarin high sensitivity troponin in China. Besides cardiac panel, there is another star panel about inflammation with PCT, which has higher specificity, interleukin-6, which has higher sensitivity, and the SCD14ST, which is unique and has both high sensitivity and specificity with giant detection. It can greatly increase the detection rate. From scientific paper published in May, in this slide, the doctor did the study by using our inflammation parameters. This study aimed to investigate whether changes in SCD14ST, procalcitonin, high sensitivity C reaction protein, and interleukin-6 level predict mortality in septic patient in the intensive care unit. Finally, they found only SCD14ST increased after 72 hours of the patient admission, which can help the doctors to define the cutoff for the patient prognosis. And another study on the same topic is ongoing in Spain. Speaking back to the routine test, one we call thyroid total solution, as we provide not only the regular tests used for thyroid function evaluation, but also the etiology of thyroid cancers and the use of thyroid sick syndrome. Given that serological testing characteristics may be significantly different in different populations, so different reference intervals were established and provided to benefit clinical practice. So we also have comprehensive panel for infectious disease as well, like TORCH, hepatitis B and C, with hepatitis A and E on the way, the fourth generation HIV with type 1 and 2 HIV antibodies, and P24 antigens, anti-TP for syphilis. All of them are CE approval, with the evaluation performed in German Red Cross Blood Donation Center. Here, I would like to share some key features about HBsAg of hepatitis B. Our HBsAg test can detect 29 mutants, including some complicated mutations, such as drug resistance mutations and vaccine escape mutations. In 2021, we successfully made a big breakthrough in Indonesia blood bank after a long-term evaluation. Now we are doing clinical evaluations in blood banks in different countries, such as Thailand, Angola, and Algeria. Besides, there are several scientific papers published with very good performance of infectious disease parameters. There are 22 regular and special markers in the tumor marker panel. They can aid in diagnosis and monitoring of many highly prevalent cancers in men and women. Although serological testing cannot replace the clinical practice of histology and imaging, but as they are non-invasive, easy to use, and they are widely applied to assist the diagnosis, treatment monitoring, and the prognosis. During the past few years, we have been focusing on clinical studies. A multi-center study has been done in China. The project lasted over 2 years, and finally, a Chinese expert consensus and 2 scientific papers on lung cancer were published. So here, I would like to make a small summary. We have different modules for different size labs, from benchtop, standalone, and integration, and TLA system, to standardize the process for operation and the construction of your lab. Meanwhile, the forecast menu to empower the clear total solution. Okay, that's all my presentation. Thank you for your attention.
Thank you very much, Dr. Tina. Now we have a final announcement, as if by any chance yesterday you had missed it. We would like to, present to you our Lab Vision 2030, which is actually an initiative that aims to create a more intelligent and a digital future for patient care. Mindray's Lab Vision 2030 is an initiative based on the idea that laboratories should move beyond their current roles of management, diagnosis, and education. Mindray's goal is to work with laboratory professionals across the globe and industry associations around the world to create a comprehensive framework for future laboratories. Mindray is a company that provides laboratory diagnostics and offers automated, scalable solutions for large volume labs, from small to large volume labs. So may I just take a minute to introduce our lab Mindray's Lab Vision 2030 initiative to you. Just a second. So this was about our Lab Vision 2030 initiative, wherein we are inviting laboratory professionals and associations to collaborate with us and to improve the future of patient care. And thank you very much once again for joining SFCC 2024. If you have any questions, you can type in the chat box. And people are asking regarding the certificates availability. So the certificate will be available on our website, mindray.com. I have just shared the link in the chat box once again. So you can just download it tomorrow. So it will be uploaded today after the validation of the email IDs, and tomorrow it will be available for download. So please do visit the website and download it. Yeah, you will also get it by email. Somebody's asking, will I get an email? Yes, yes, sir. You will get it by email also. And if you have any queries, you can write to us on our email ID, or you can connect with us on our WhatsApp number. I'm just typing it on in the chat box. So if you have any query regarding this program, somebody is asking, I want to connect. So yeah, yes, sir. I have just dropped the email ID and the phone number, the WhatsApp number. So please do let us know if you have any further queries. So thank you very much for joining, and looking forward to see you again. And we will be posting a lot of content related to this event on our YouTube channel. So please don't forget to subscribe to Mindray India YouTube channel for interesting short story content and things like that related to this event. Thank you.